headphones and wait as we prepare for the session. Thank you.
Improving healthcare is a key priority for all countries in the world. Digital health has proven to be a very effective tool in improving quality, access, and cost of healthcare. Consequently, digital health is one of the fastest growth areas in technology. India too is investing heavily in digital health technology. The government is rolling out the Ayushman Bharat digital mission across India, which will drive new healthcare solutions, similar to the impact of Aadhaar and UPI on financial solutions.
Digital health, it has substantial benefits for healthcare and its stakeholders, patients, hospitals, government organizations, doctors. We are really excited to support IIT Bombay in setting up the Center for Digital Health.
Koita Center for Digital Health, or KCDH, drives research, entrepreneurship, and employment in digital health.
The center is the first of its kind in India, and our vision is to establish KCDH as a globally renowned center in digital health and digital health informatics.
KCDH is proud to have a world-class advisory board with renowned members from diverse backgrounds, including directors of renowned hospitals, professors from top universities, and a senior executive of leading health tech firms.
We offer world-class academic programs in healthcare informatics and groom an exceptional career of students. Faculty and students work on fascinating projects through internships and placements at some of the best companies.
The center offers a wide range of courses in computer science, AI and machine learning, medical imaging, healthcare data management, healthcare economics, and healthcare ethics. These courses are taught not just by IIT faculty, but by faculty visiting from various leading hospitals and research institutes.
Partnering with expert clinical professionals, that's our key priority area. The center is actively involved in applied research, development activities, and facilitates collaborations between engineers, clinicians to solve real-world healthcare challenges with access to clinical data and expertise.
We are establishing collaborations with leading hospitals, healthcare organizations, and healthcare regulators to drive collaborations in research and teaching programs, funding, and policy. The center is committed to providing meaningful internship and career opportunities for our students.
Digital healthcare is poised for a massive transformation in India. We are excited that the center can contribute to accelerating digital health adoption in India, which in turn will positively impact healthcare. We invite you all to join us and be part of our center.
Ladies and gentlemen, our next session is about to begin. May I request you to kindly mute your microphones and wait as we prepare for the session. Thank you.
Now, I would like to request to Professor Ashutosh to drive this session. Thank you. Over to you, Professor Ashutosh.
Thank you, Rasmi. So this session is a spotlight on the project funded by KCDH, and yeah, we will be having a short presentation by each of the faculty who got the project from KCDH. So we will be starting with Professor Biplav Banerjee, and he is collaborating with Dr. Barnali Das. So yeah, Professor Biplav Banerjee, you may start. And we will be having about 8 minutes of presentation and 2 minutes of discussion, some interesting questions that may come up during the talk. So we'll have 2 minutes for the discussion.
Thank you. On behalf of Professor Biplav Banerjee, I am going to present. I'm Dr. Barnali Das from Kokilaben Dhirubhai Ambani Hospital. So thank you, organizers of Professor Rinty Banerjee Memorial Conference and Koita Center of Digital Health for organizing this conference on translational research in medicine. My heartfelt tribute to Professor Rinty Banerjee, and who spearheaded translational research in medicine. So my heartfelt tribute to Professor Rinty Banerjee. So now I'll start my talk and presentation. So you can hear and you can see the slides.
Yes, Dr. Das, please go ahead.
Thank you. So the genesis and the problem statement of this project with Professor Biplav Banerjee from CSRE and CMeans of IIT Bombay to develop machine learning based models and web-based tools to predict the mild, moderate and severe case of COVID-19 based on routine lab biomarkers. So if you want to hear the story, how this project, like the genesis of the project, this started around 2020 March. This is one case of 56-year-old physician. He had fever, cold since 6 days associated with cough, with expectorant, severe body ache, decreased appetite. He was mild hypertensive and history of contact because he was treating the patient, and that time March 2020 the COVID-19 was just started spreading. So, and history of similar complaints in close family. And if you remember that time hydroxychloroquine was very popular drug and we used to take that as a prophylaxis. So he started hydroxychloroquine on day 3, and day 6 he came to hospital and his RT-PCR for SARS-CoV-2 was positive. Now see, he is positive. He was having high-grade fever. Now the markers, how the hematological biochemical markers or routine lab biomarkers predict the disease or help us in therapeutic monitoring and staging the disease. So these are the very common routine lab markers which we do in day-to-day practice, like transaminitis. If you see liver function test here is deranged, and the coagulation markers like LDH is deranged, D-dimer increase, ferritin is an inflammatory marker that's increased, and the blood gas analysis showed deranged, SO2 percentage 72.4%, hemoglobin was decreased, and neutrophil lymphocyte count deranged, neutrophil increased and lymphocyte decreased. So NLR ratio, neutrophil lymphocyte count abnormal, platelet count decreased, and CRP is one of the most useful biomarker we realized during this COVID-19 times, COVID-19 diagnosis and prognosis. Sometimes in resource poor setting, C-reactive protein is one of the most useful markers for prognosis after COVID-19 diagnosis. Procalcitonin is for bacterial superinfection, but usually in viremia it remains low. And interleukin-6, this is a one cytokine. For this patient, if you see all those markers showing cytokine storm is raging. So for this, interleukin-6 is increased. So now the course of his treatment, initial treatment was paracetamol, ceftriaxone, hydroxychloroquine, but there was persistent high fever, day 9, increasing C-reactive protein, ferritin was increasing. They started lopinavir, ritonavir, single dose, but they have to stop because there was a high QTC interval, fever increasing, patient was desaturating, chest X-ray showed bilateral infiltrates, so cytokine storm is raging, high fever, increased D-dimer, increased ferritin, increased LDH, increased interleukin-6 or cytokines. So this is a case of acute lung injury or adult respiratory distress syndrome or acute respiratory distress syndrome, ARDS. So that time in India, tocilizumab just started coming. So tocilizumab is interleukin-6 receptor blockage. So they started tocilizumab 400 milligram repeat dose after 1 day, but even then fever was persistent, inflammatory markers increase, oxygen requirement, and the patient was desaturating. And then they started all the treatment they tried. It was trials, all the treatment they tried, but ultimately they started methylprednisolone 30 milligram twice daily for 3 days. Then fever subsided, decreased C-reactive protein, no oxygen requirement, and patient after 20-25 days of roller coaster rides, patient got discharged and recovered. So this is a case of 56-year-old physician, and this is the genesis of our project. So these are some of our papers of evaluation of role of routine lab markers, biomarkers in COVID-19 patients. And during second wave or the first wave, later stage, we had sudden cardiac death. Post-COVID multi-system inflammatory syndrome or organ damage, we heard about there is sudden cardiac death. So because of that, cardiac biomarkers played very important role in COVID-19. So these are some of the how cytokines and lab biomarkers, routine lab biomarkers delivered value to us. So because of that, the biochemical monitoring or hematological monitoring of COVID-19 patient is critical for assessing the disease severity and progression, as well as therapeutic monitoring, like I said, for tocilizumab, the basic interleukin-6, CRP level they used to see. So because of that, we studied the role of all the biomarkers, and based on statistical analysis, we'll derive the algorithms in mild, moderate, severe COVID cases, because we realize risk stratification is very important. And that time we realize knowledge, because we are not expertise in machine learning or deep learning. So knowledge of how to develop the algorithm and the expert is very much necessary. So to implement the correlation analysis based algorithms of routine lab biomarkers like C-reactive protein, lactate dehydrogenase, interleukin-6, ferritin, D-dimer for predicting the severity of ICU admissions or risk stratifying mild, moderate, severe cases are very important. So we thought if we can develop web-based tool based on our routine lab markers, and then if we can clinically validate that to develop a predictive model based on machine learning or deep learning based technology. So this actually the different stages, like initial stage, viremia, mild constitutional symptoms, fever, dry cough, diarrhea, headache. So there we see lymphopenia, increased prothrombin time, increased D-dimer, LDH mild increase. Then acute pneumonia stage or pulmonary stage, we should see shortness of breath with abnormal chest imaging like bilateral infiltrates or transaminitis, ALT, AST raised, liver function test deranged, low normal procalcitonin. And recovery phase, we see host inflammatory response where we see acute respiratory distress syndrome, syndrome, elevated inflammatory markers. So these are several markers we have studied, and these are due to sometimes due to the decreased immunological response to the virus. And
can you finish it off, please?
Yes, yes. So this, I want to finish with this case. This is like one 43-year-old with mild fever for 2 days, and you see battery of tests they have done. All those tests, TLC to CBC, CRP, IL-6, procalcitonin, D-dimer, even HRCT. So with all the these tests are unnecessary for this patient. So because of that, this right time, right patient, and right tests are very important. So this is very mild case. We don't need all the markers. So for that, we need smart biomarkers, specific, sensitive, measurable, available, and affordable, and responsive and timely. So because of that, rule of 6, like CRP more than 60, ferritin and LDH more than 600 nanogram per ml. So that's sufficient for any mild fever case. So because of that, the need of this project, we realized, I already stated the objectives. And so this, we felt that to develop the risk prediction algorithm for COVID, and this will contribute to great resource utilization and decrease the patient's financial burden too. So thank you very much.
Thank you, Dr. Das. I think there is a time for a quick burning question, if anyone has, or suggestion is also okay. These are projects. Okay, I don't see any hands or any. Okay, thank you. So next project is all by Professor Suili Mukherjee and Dr. Bernoli Das. I don't know who is presenting, you, Dr. Das, or?
Yes, and Professor Shuli is also there, so she will comment if, where I am stuck with the project.
Sure, please go ahead.
Thank you. So with Professor Shuli Mukherjee, we started this project, the implementation of electronic alert system for acute kidney injury in hospital setting and development of web-based tools for National Public Health Advisory in India. So this is our project title. So again, the genesis is based on public health perspective, acute kidney injury, because this is abrupt decrease in kidney function, which results in accumulation of metabolic waste products, as well as dysregulation of volume status, electrolyte and acid-base balance. And we have seen 5% to 20% of all hospitalized patients carries a significant independent risk of mortality of 20%. So acute kidney injury associated with adverse outcome like chronic kidney disease and end-stage renal disease and dialysis, and mortality is also very high. So globally 13.3 million cases every year and 1.7 million deaths, and the low-income countries or developing countries 11.3 million cases per year and 1.4 million deaths per year in low and middle income countries. So because of that, electronic health record or e-alert can modify patient outcomes, contribute to great resource utilization, and also decrease the healthcare cost and financial burden. How? So this is like, if you see this paper, they have shown around 0.8% reduction in mortality, length of stay 0.3 days reduction, and dialysis use 2.7% reduction in dialysis use. So because of that, Kidney Disease Improving Global Outcomes, KDIGO guidelines advise identification of AKI-based or acute kidney injury based on increase in creatinine. Because we know creatinine, most of the OPD patients and IPD patients, when they come, they do creatinine. So based on KDIGO criteria, is very routine for us to diagnose or to identify the acute kidney injury. But serum levels of creatinine here are mildly increased. Because of that, many times is not detected by clinician. So early intervention is unlikely. So this cause burden of disease. How? So this is our criteria around 0.3 milligram per deciliter within 48 hours creatinine raise, or 1.5 time raise in creatinine from the previous measurement in 7 days. So if you see 0.3 milligram per deciliter creatinine, many times clinicians or many times they miss checking the value as minimum as 0.3 milligram per deciliter. So, and these are the different stages, like stage 1, stage 2, stage 3, like from 1.5 times to 2 times raise is stage 1, stage 2 is 2 to 3 times, and more than 3 times or more than 4 milligram per deciliter is stage 3. So here in our pre-implementation phase, we have observed, we have done one pilot project, and in that we observed that electronic health record or e-alert in our hospital setup, it has around sensitivity of 99.53% and 98.60%. And our overall hospital mortality due to acute kidney injury 21%, and only 40.2% patients have documented clinical diagnosis of AKI or acute kidney injury. So this is where we find the gap. Only 40% patients were documented for AKI. So this is our small pilot projects around 4,708 patients, and included is around 4,439. And AKI e-alerts was raised in 273 patients, and in 273 true AKI e-alert was 239, rest were false AKI e-alert, and false is 34 cases, and total non-AKI patients is 4200. So if you see, this is the AKI alert detected by this 239, and this is non-AKI. So this is the graphical representation of true AKI e-alert, and these are the different stages, like stage 1 detected in 202, 18 stage 2, and 19 stage 3. So now this is the clinical validation of that study. So 2,000 patients we have taken as a clinical validation, and in that we included around 1,799 patients, and number of AKI e-alerts was raised in 143, and number of patients with documented AKI diagnosis by clinicians were only 46. If you see, we have allotted 143, but documentation is only 46. So around only 32.17% cases was documented as AKI. Suppose there is no e-alert, we would have missed the rest of the cases. So this received 2021 Universe of Healthcare Achievement Award. So there was 188 project, and in them around 7 projects were selected globally. So this was one of our like AKI biomarkers. But now coming to the role of like we wanted one troponin is for the acute coronary syndrome, same we wanted for acute kidney injury. Now when we started this project, we realized that we have done that pilot project. Then Professor Shuli Mukhopadhyay came, and she suggested us, and we realized that we can implement that in a bigger picture, and we can really help to develop the AKI based web tools or AKI e-alert, and we can also study the epidemiological trends of AKI in Indian population, and we can evaluate the sensitivity, specificity, and accuracy. So we are planning to do one small study with urinary NGAL and different other markers like KIM1 and FABP and TIMP2. These are the biomarkers for AKI, and we will evaluate with this. So need of this project is because AKI is hard to diagnose due to asymptomatic presentation, with about 50% cases being missed, and without timely diagnosis and intervention, the disease may progress to chronic kidney disease or end-stage renal disease or dialysis. So AKI prediction system in India are almost non-existent, and most of this focus solely on the critically ill intensive care units or ICU patients, or those undergoing specific surgical or cardiovascular procedures. So no AKI risk scores built for Indian patients. and that has not been incorporated in patients' other variables like vitals and other non-renal lab values. So Professor Shuli will help us to study those variables along with the implement that AKI-based tools and in the bigger picture, in bigger scenario, and this can modify patient outcomes, contribute for greater resource utilization, and this study will help to identify the epidemiological trends of AKI patients in Indian hospital settings. This advantage is like get the data, apply the rules based on the expert available in Quetta Center of Digital Health, and clinically we will validate the data and it will deliver high quality care with patient-centric insight. It reduces the variability through consistent guideline-driven recommendation and improve workflow and efficiency. So for us, every blood sample tells a story. Thank you.
Dr. Das, I lost your voice somehow towards the end. Okay.
You can't hear me?
Yeah, now it's fine. In like for 10 seconds we lost it. So it's done, right? You are done with the presentation.
Yes, yes.
Thank you very much. Any question on this project from anyone in the audience? Okay, if not, let's thank Dr. Banali Das. And next presentation is by Professor Ganesh Ramakrishnan from Computer Science Department of IIT Bombay on his project.
Thank you, Professor Ashutosh. I hope you can see my slides here.
Yes.
Okay. So I'll be talking about efficient AI and deep learning in medical applications. When I talk about efficient AI, I largely talk about data efficient AI. Often in medical applications, what you're trying to find is a needle in a haystack. This work is joint work with both Tata Memorial Center, some of the work that we're doing with Tata Memorial Hospital, especially with Dr. Hasmukh Jain, and some of the work we've been doing with Narayana Hridayalaya. I'll be presenting glimpses of both, especially Dr. Devi Prasad Shetty. So there's a lot of background work we've done with my collaborator and also IITB alumnus, Rishabh Iyer, where we built an entire platform for data efficient machine learning. One of the biggest challenges in using machine learning models in operational settings is resource constraints. You don't have too much data to begin with. So we built this data efficient machine learning platform, which has especially two components relevant to the work today we are presenting, which is targeted subset selection, where you don't have much labeled data, but you have exemplars or examples of labeled data. And the other is semi-supervised data programming, where you can make use of previously encoded rules, best practices from the medical practitioner with unlabeled data, no label on the data, and get started. I'll start with an example here. So imagine that you have lots of data with confusion matrices presented here. And let's say there are a lot of false positives. You're trying to reduce the false positives. So you're trying to create a target, which is the false positives which you want to reduce, and increase the number of true positives. So you can create the target, based on the target, you can actually identify a subset of your large unannotated data set. In the image setting, let's say I have a lot of nighttime images, and I want those to be the target. I have a large unlabeled data set, and I want to identify from this unlabeled data set those which are very similar to the target setting. So of course, this targeted subset selection is available for download as an open source platform. I'll give some more examples. Let's say you have looking at retinal fundus multi-disease data set, where you have lots of eye-related diseases, but the diseases are very skewed. As you can see, some of them have very few samples, rare classes. These are called rare classes. So how do you make the number of normal samples of certain rare diseases higher in number? How can you help the clinician identify more samples of the similar type? Okay. So one solution is acquire medical images that maximizes what we call the information gain for a target disease model. For example, if you're interested in the vasculitis, which is inflammation of retinal blood vessels, choose images displaying those symptoms. Now, acquiring fresh data points which target that rare classes can help mitigate the problem, right? So we're looking at, say, samples of type B, which is what we want, but we don't want samples of type A, which is microaneurysm, or we don't want samples of type C, which is branch retinal artery occlusion. So make the B our target and make the red our refrain, so that the new samples that you identify can efficiently make use of the clinician's time, and also in the process increase the balance in the data set. Often, as I said, finding diseases is like finding needle in a haystack. So you have large imbalanced data set, but through this process of identifying the target and maximizing your information functions with respect to very sophisticated, very representative functions called submodular functions, you can identify the subset that will help you create less Q and more balance. Let me give you one more medical application now. Imagine that you have a lot of unlabeled data, but you don't want to just use the unlabeled data as a spectator to create your labeled data. We want to use the unlabeled data also as part of your model. So you can also do that. You can have information functions, acquisition functions that can help improve the semi-supervised learning models deal with more balanced data. And that is through this active semi-supervised learning. So you're going back and forth to the data. You have a lot of unlabeled data. You probe it using your information functions, acquire the data set to be labeled, and in due course of time, you have a very balanced labeled data set. A third application is when you have out of distribution data sets. Often the kind of models we build in one country for one kind of demography, often for one kind of population, doesn't generalize to the other. And that's what characterizes out of distribution data. But you can have other finer notions of out of distribution data. For example, wrongly acquired images due to different factors such as underexposure, overexposure. Or you could have out of distribution because of different view of organs, axial as against sagittal or coronal planes, right? So this will probably help you appreciate better. So you can see that there's a deer and a bird. Obviously, these are out of distribution if you're looking at certain kind of eye disorders. But there are finer notions of out of distribution based on different population or based on different views, based on different factors such as underexposure, overexposure. So again, you can avoid out of distribution data using information measures where you're trying to maximize similarity with what we call the target, the I, and have as much dissimilarity as possible with the refrain or the out of distribution, the O. So the work based on this prior work we have done, the current work we are doing with Tata Memorial Hospital, Dr. Hasmukh is use of data deep learning in predicting outcomes of patients with hematological malignancies. The challenge again here is that we have very less labeled data. So Hodgkin lymphoma is a malignancy arising from B lymphocytes, is characterized by heterogeneity in terms of both pathology and clinical behavior, and it's important because it accounts for 15% of all the cancers that you see in young adults. But the challenge is to be able to identify the groups of patients at the earliest with high specificity, sensitivity, and positive predictive value. Now in the second cycle, it's only after the second cycle that an interim PET scan, CT scan, can help change the therapy. So you need a robust prognostic system that can help decide the intensity of the therapy at the baseline. So here we invoke another related low resource labeled setting. It's called semi-supervised data programming, and I'm going to illustrate that for this medical application. So the idea here is domain experts. Dr. Hasmukh, for example, he has for a long time been making use of certain rules to identify and diagnose. So these can be, these rules can assist the pathologist rank the severity of Hodgkin lymphoma. However, they have a limitation. They don't make use of the unlabeled data set. So therefore, we leverage weak supervision, which is a combination of predefined set of rules, heuristics, and associated noisy labels that emerge from these rules or heuristics. And what is an example of these labeling functions? These could be as simple as bounding boxes of Hodgkin lymphoma cells or the cancerous regions in PET CT images, making use of lots of conventional image processing. These noisy labels will be aggregated to assign labels to the unlabeled data set, which is a large slides of the SME diagnosed for Hodgkin lymphoma for the downstream task. I'll talk about my last set of medical applications. This is largely work with Narayana Hridayalaya. This is about targeted learning and data programming both combined together. So the challenge here is there are a lot of medical records, handwritten and typed both. And this is a problem also prevalent in lots of HMIS, hospital information management systems. One of the challenges is layout. These have very complex layouts. So how do you identify the text, the images, the tables, the symbols, and different fields? What is a recommendation? What's a prescription? What's a diagnosis? And the amount of data that is annotated is again very limited. So,
sir, can you please conclude?
Yes. So what we try to do here is data augmentation. I'm going to just conclude this very quickly. So one approach here is you can identify the target regions which are very difficult to identify to select documents that contain similar tables. For example, table is very difficult to detect, for example, in optical character recognition. The other approach we have is use of programs. Programs can be, as I mentioned in the case of Hodgkin lymphoma, they could be just bounding boxes. So here are bounding boxes identifying regions which have very clear, definite diagnosis of diseases. I'm going to conclude with this. Thank you very much for your attention.
Okay, so any question, any comment from the audience?
Yes, so I have a question. Thank you for the presentation. Is your approach distribution free? I mean, I'm assuming it's quite completely non-parametric. Is that correct?
Yes, it's non-parametric. That you're right. It's distribution free.
Yes, and maybe for the audience, which seems to be quite clinical, I'm just wondering whether you want to share your experience of transferring some of the mathematical computational concepts like you presented, which is such a contrast from the previous two talks.
Right.
So how do you interact with the clinicians to get the ideas across? What is the strategy, practical strategies you apply? What works, what doesn't?
Very good question. Thanks for that. For me, the main interaction point of a clinician is how would they go about diagnosing as on today, right? As I said, sometimes they subscribe to conventional image processing. They have rules. There's sometimes text-based rules as well. Combination of multiple, biomarkers that they have measured. So we go with what they begin with, where they are, right? So that's what we call, we talked about this data programming labeling function. There's in fact a very big platform from Stanford called Snorkel, which lets domain experts encode their prior beliefs. So that's where I would begin with, right? Interact with clinicians and request them to encode their logic in as simple a language as they can, and then try and transfer them into the framework, for example, that we have created. Does that help, Dr. Nitish?
Well, I'm trying to help your audience in the sense that there is a bridge between your rigorous computer science with some other mathematical foundation and the clinicians who have real patience and record. And having a language where both can appreciate each other is important. And hopefully you can either not only just present your work, which is very specialized, but rather the process. And that would be worth having a discussion among all of you who are awarded this COITA grants, But that's all. Thank you.
Thanks, Dr. Nitish. We will take it forward.
Thank you, Professor Ganesh. Yeah, thank you, Professor Ganesh, for this wonderful presentation. So next, I would like to call Professor Shavik to present his research work. Professor Shavik, over to you.
Yeah, thank you, Rashmi. Let me try sharing my screen.
So I'm requesting to you just finish your research work presentation within 10 minutes. Otherwise, we'll...
Sure. Sure. Okay. Is the slide visible, Rashmi?
Yeah.
Okay. Thanks very much. So the title of this project is Assessing Quality of Cancer Care in India Using Electronic Medical Records, and it's a pilot study. The digital health partner is Dr. Shorbani Ghosh-Laskar from Tata Memorial Hospital, who is a professor and clinical oncologist. And the partnering institutions we have for this study are multifaceted. So from the IIT Bombay, we have Professor Ganesh Ramakrishnan, who will be spearheading the AI and machine learning parts in terms of how we parse the data from electronic medical records for particular clinical indicators for cancer quality. And then along with different clinical partners that we have, including Tata Memorial Hospital from Mumbai, the Kachar Cancer Hospital Research Center in Silchar, Assam. Then we have the Malabar Cancer Center in Kerala, Cancer Center Adyar in Chennai, Amrita Institute of Medical Sciences, Kochi, Kerala, and Max Super Specialty Hospital, Saket in New Delhi. So in the first year of the project, the goal is to identify, and we already have initiated work in this area, that we've identified 3 hospitals who have provided their consent to be part of the study in the first year, essentially Tata Memorial Hospital, Kachar Cancer Hospital and Research Center in Silchar, Assam, as well as the Malabar Cancer Center in Thalassery, Kerala. And so I'll just give a brief background in terms of motivating our study. So there are routine assessments of quality of healthcare in many developed countries, including the US. So for example, the readmissions reduction program, the value-based purchasing program in the US, which all measure different quality of care metrics along multiple dimensions, including clinical appropriateness of care, efficiency of care, timeliness of care along multiple domains for a lot of hospitals which are Medicare reimbursed through Medicare, for example. And many of these hospitals are, part of their payments are withheld, or they could be reimbursed a higher amount, depending on how they perform along these different dimensions. So there is routine assessment of performance of different hospitals and the kind of services and the quality of these services that they render to patients across the board. However, so it's not, the study is not novel from the perspective of any developed country, but in the Indian context, the reason why this is so important is that particularly in the realm today, with the National Health Policy and the launch of the National Digital Health Mission, there has been more emphasis on providing affordable and quality healthcare services to all. However, while at the same time we are talking about improving access and improving quality of care, there is no good way how we are measuring these quality metrics across different disease spaces, for example. So in this project, what we seek to do is we have identified 6 cancer centers, spatially diverse, some from the north of India, some south, one in the western part and the other in the eastern part, which are diverse not only in terms of spatially, but also in terms of the patient characteristics, the volume of patient that these institutions serve. And what we want to do is identify some identifiable cancer quality metrics for which will be determined from the electronic medical records of these cancer centers, starting as a pilot. And then we want to extend this to other cancer hospitals. Not only that, but we ideally can also look at other disease spaces. So this is not specific to cancer, but the idea is that we want to capture the process starting from the electronic medical records, and not all data are extractable very easily. Some may be handwritten notes. So from there, how do we get that into a digital form and then extract that information, given that not all these institutions have a uniform electronic medical record system? Okay. So there is a need to identify metrics for quality of care along multiple dimensions, obtain the relevant data digitally from these different healthcare systems, organize and integrate the data thus obtained, measure the quality of care metrics which are identified, and finally suggest ways to improve upon the efficiency of the processes involved in digitization and extraction of the data. Ultimately, what we want to do is essentially outline the process that we have undertaken so that this is helpful for other hospitals and institutions as well, so that they are able to replicate or follow the process in their digital systems as well. So we focus on oncology primarily because our study team is specialized in that area, and we're focusing on oral cancer and breast cancer, which are widely prevalent in the country. The domains of care quality and the clinical indicators that we will be focusing on are the following. And these are only some examples of the clinical indicators that we will propose to explore. Of course, this list may be modified depending on the nature of the data that we can extract from the electronic medical records of each of these institutions. So these will be finalized at a later point. But just to give you an idea of what are the metrics we are thinking of, the clinical quality of care dimension includes metrics such as the time between registration in hospital and the initiation of treatment, proportion of patients who start treatment based on a tumor board plan, time between curative surgery and start of an adjuvant radiotherapy or chemoradiotherapy, and similarly, time between curative surgery and end of adjuvant radiotherapy or chemoradiotherapy. And you will see that some of these, there is overlap across some of the other domains as well, which I will point out. The next broad domain that we focus on is communication and care coordination. So the proportion of patients which are to be discussed pre and post-operatively by a multidisciplinary team, patients with breast cancer who develop metastatic disease having their treatment and care managed by a multidisciplinary team. So one of the goals that we hope to achieve with the National Digital Health Mission is integration and care coordination, because as of now, patients can go to multiple centers and get treatment from multiple physicians, but all that information is somehow lost in the process if they are not digitally captured, and if each of these institutions are not talking to each other in the sense of sharing their data. So we want to assess to what extent there is communication and care coordination, safety in clinical care, which includes the proportion of patients having toxicity documentation during radiotherapy, as well as the proportion of patients which have surgical morbidity documented during surgery. In terms of timeliness of care, these are common as well. We have also looked as some of these in terms of the clinical quality of care. So the time between registration in the hospital and initiation of treatment, time and days between curative surgery and start of radiotherapy or chemoradiotherapy, and time between curative surgery and the end of radiotherapy, for example. Then we also want to assess whether there are inequities in clinical care that is provided to the patient. So essentially, many of the metrics that we have noted, we want to compare these clinical indicators between the general or subsidized versus public pay, populations and compare them with those who are privately insured or have insurance. Okay. So very briefly, the specific aims of this study, and there will be a part which is based on AI and machine learning, which I will not get into. But the specific aims of the study are the following: that we want to identify a core set of desirable and appropriate quality metrics in oncology care and describe the basic minimum data required to construct these metrics. So overall, our goal is to extract meaningful information along multiple dimensions.
Professor, I just would request you to conclude the session. Yeah.
Sure. Yeah. So the overall goal is to identify these quality metrics, which can be extracted from electronic medical records across varying institutions, and which can provide meaningful information about the quality of care. Secondly, evaluate the feasibility of digital extraction of this data across different EMR systems. And we'll look at data which are present and extractable, present but require a significant manual intervention, present but which may not be easily extracted, and not present in the EMR at all. So extraction of these clinical indicators will be based on robust data programming using weak supervision and semi-supervised learning if required, including, especially for data that is present but not easily extracted or extractable in the form of, say, handwritten notes. Those we will also explore OCR approaches. And we'll implement a subset of these quality metrics that's feasible and ultimately provide recommendations for setting up measurement systems that can leverage EMR systems to monitor quality of care. And ultimately, we want to provide recommendations as to how we can improve the quality of care which is rendered in oncology space. Thank you.
Thank you, Professor Shovik.
Sure.
Any question from audience? Any comment? So I think we don't have any. So thank you again, Professor Shovik. Now I would like to invite Professor Ajit Rajwade for the next talk. He's from CSE department. Professor Ajit, over to you.
Yeah. Am I audible?
Yeah.
Yeah. And is the screen visible?
Yeah.
Okay. So thank you for organizing this. So my talk is about image reconstruction, specifically algorithms for reduction of radiation administered to patients in longitudinal computed tomography. So this is a project I've been working on with some doctors at Tata Memorial Hospital for the last 2 years. There's Dr. Nitin Shetty and Amit Chowdhury from the Department of Radiology at TMH. I've also in the past worked with Dr. Akshay Baheti. And I'm grateful to KCDH for funding this project in this particular round. So I'll give an overview of what this is. Tomography is the process of estimation of the inner structural details of an object. So for example, I've shown you a pear here. You can cut the pear and you can observe the parts in it. But if you have to observe a patient, you cannot do that, or it's not advisable to do that. So you take CT scans of this patient. All right. And essentially what a CT scan does is that it actually it sends X-ray beams through the patient's body. So here's a 3D object, and X-ray beams are sent in multiple directions, and corresponding to each direction, a 2D X-ray image is acquired. It's called a projection image. And then somehow these projection images are combined by the software inside the CT scanner, and the complete 3D structure of the person's body is obtained. So this is not just the surface structure, but also the internal details such as the lungs, the heart, the spine, etc. Now, the more is the number of angles through which X-ray beams are shot through the patient's body, the better is the quality of the reconstruction. Okay. Also, the higher is the beam power, generally, the better is the quality of the reconstruction. And this has a harmful side effect. High radiation can be very harmful. It is harmful for patients, particularly pregnant women or neonatal patients, babies. It's also actually harmful to doctors and technicians who are sitting in the room because there are a lot of harmful backscattering effects that occur. So there is interest in the radiology community to design algorithms that enable reduction of radiation dosage administered to patients who are undergoing repeated CT scans in a manner such that the reconstruction quality is not hampered. Because if you just reduce the number of angles or if you lower the beam power, then you start getting poorer quality reconstruction, which can interfere with the diagnosis. Okay. So in this particular project, our idea is that if a patient is coming for multiple scans, okay, so this is called longitudinal scanning. Then the first few scans you can acquire with high dosage, large number of angles, high beam power. And the subsequent scans, you can reduce the number of angles or reduce the beam power. Now, because the reconstruction quality can be adversely affected, what you can do is that your past 3D reconstructions can be made to act as guiding templates for the subsequent reconstructions. All right, so this is actually a very, very simple idea, and it is useful in things like longitudinal head and neck cancer scanning. It's also useful in certain CT guided surgical procedures, which I will describe. All right. So there are basically three modes of radiation reduction. One is called few views, where we reduce the number of angles of projection. Then low power, where you have low power X-ray beams. And the third one is a combination of both. So few views and low power. All right. So there's a process called CT guided ablation. We got data from Tata Memorial Hospital for this 2 years ago. So in this process, a needle is inserted underneath the skin of a sedated patient, and the needle is moved closer towards the tumor. So there's a cancerous tumor, let's say in the liver, and you want to burn the tumor. All right, the moment the needle reaches the tumor, you can burn the tumor from the tip of the needle. But the moment the needle goes beneath the patient's skin, you cannot see it any longer. So you need to keep taking CT scans of the patient in order to track and see the position of the needle. All right, so there's a lot of unnecessary radiation being administered to the patient. So here again, our idea is first few scans we acquire with high radiation, later with lower radiation, using the earlier ones as guiding templates. The challenge here is that there are going to be genuine differences between the first few scans and the later scans. So you can't just copy the earlier scans for the sake of image quality. You have to keep track of genuine anatomical or structural differences between the later scans and the older ones. For example, when you burn the tumor. So here is where the machine learning part or the AI part is really, really useful. So I'll show you some sample results based on our previous work very quickly. So here is a few views result. Okay, so here we have a test scan. This is the ground truth, and this is the reconstruction with our algorithm. Here I'm showing a video where the depth dimension is shown for time. All right, at some point you'll see the needle entering. All right, and the needle is the needle position you can see. So there's a very good match between our reconstruction and the ground truth here. Although the number of angles was reduced by a factor of 60%. So if there's Nyquist, which is 180 angles, we make do with just 90 angles. Okay, so that's or 80 angles, which is a factor of more than half. All right, and there are various intermediate images here, which I will not show, but in particular, you see some residual images. These show the difference between the test scan, okay, from the measurements compared to the guiding templates. All right, so this is one reconstruction result. If you ignored the fact that you're undersampling, you get a lot of streaking artifacts like you see over here. So this is one result for few views on data acquired from TMH. This is a result on low power beam. So you see this, there's a lot of noise in this reconstruction. On the other hand, we have our result, which combines the guiding templates with the present low beam power reconstructions using some kind of intelligent fusion. All right. And here are the residual images that we have, which show the differences between this image and the, the guiding, this and the templates. So here you see, you can compare the quality difference between this and the image over here, all right? Although the reduction in radiation dosage was more than a factor of 50%. So, so despite that, because we were using the earlier scans in an intelligent manner. So these are two sample results. There are a lot of technical details which I simply don't have time to go into, but I'll be happy to talk to people, students who are interested in working on this particular project. The work to be done is that, first of all, we've done some validation on CT guided ablation data, which the radiologist actually liked, but we want a larger team of radiologists to validate this, and we want to validate this on a much larger data set. So that's one aim. Then there are certain spatial alignment issues between different scans, and there is scope for usage of even better reconstruction algorithms, for example, ones that use machine learning and deep learning techniques. Lastly, we want to do validation on longitudinal head and neck cancer scans. That is more challenging than CT guided ablation, because in CT guided ablation, the scans are taken in quick succession. In head and neck cancer scanning, the time gap between different scans can be more than 1 month. The long-term aim is to bring in intelligence into the way CT scans are acquired of patients, particularly for longitudinal applications, so as to save the amount of radiation that is being administered to patients and technicians and doctors. Okay, what I'm looking out for is one enthusiastic IEEE student with whom I'll hopefully enjoy working. On this topic, my PhD student Preeti Gopal did a lot of work, although at that time we worked only with botanical data because it was hard to get this data, and some amount of data from TMH we worked on. My earlier MTech student Yadnesh Patil also worked on a lot of the algorithms. I also have another master's student Anmol this particular year. We published 2 journal papers, 1 conference paper, and a bunch of paper abstracts, poster abstracts in different conferences based on this topic so far. Okay, so with this, I will conclude my presentation in the interest of time. I'm happy to answer questions or address any comments or concerns.
Thank you, Professor Ajit. Any question from audience? Any comment? Okay, I think we don't have any. So let's thanks to Professor Ajit, and we welcome Professor Vikram Gadri from EE department. So over to you, Professor Vikram.
Am I audible, madam?
Yeah, you are audible. Yeah.
Mine will be a very brief presentation. Actually, my project is still, in some sense, in the inception stage. So I'll just share a couple of slides. Yeah.
Sure.
So are they visible?
Yeah.
Okay. So I have just a couple of slides. In fact, this is still in the stage of discussion. But of course, we do plan to pursue it once we have clarity. I'll just give a background to what led to the formation of this idea. And you see, there was some discussion with AIMS again, but more specifically with, in fact, let me go to the second slide, with Professor Rama Jayasundar. Is my cursor visible from AIMS? So, she's currently, I think, heading the radiology department. And she has a huge amount of data, particularly MRI data on fMRI data. Functional magnetic resonance imaging data on the what happens when certain known what you might call traditional techniques in the Indian wellness systems were practiced. So now the background is that in the new education policy, let me go to that slide right away. I'll come back to the slide later. So, one of the tenets of the new National Education Policy 2020, NEP 2020, is what I've listed here. Given that people exercise pluralistic choices in healthcare, our healthcare education system must be integrated, meaning all students of allopathic medical education must also have a basic understanding of these systems, other systems. Now, of course, there is also a greater emphasis on preventive healthcare and community medicine. Now, if you ask me what is one central idea in the work that we wish to pursue, it is in our technical education institution framework. If we could look at data that can substantiate this recommendation or directive of NEP 2020 to systematically study the broader systems of healthcare and healthcare education. For example, there are known methods of yoga and pranayama, which are being studied scientifically today. And this can be done very well with a lot of signal processing and machine learning techniques. So this is, if you ask me, in a nutshell, or a description in a nutshell of what we want to do. Now, a little more background on what we are going. Maybe I'll just go in the reverse order of slides. So the background I've given under NEP 2020, we would like to look at traditional systems of healthcare. And of course, we'll also look at traditional biomedical, the known biomedical systems like ECG, EEG, and so on. But we would like to bring together the traditional systems of healthcare as per NEP 2020 with what we know of some of the signal and image processing methods to understand what happens when these techniques are practiced. Now, this is a quick overview of what we want to do. So essentially a biomedical signal analysis with this union of approaches. It so happens that we have a PhD student right now. Professor Soumya Mukherjee is the guide. Mr. Nitin Lakshmisha is already working in the Department of Bioscience and Bioengineering, but he's working on fetal ECG and he's using multi-resolution machine learning. So what we would like to do is to take this idea of multi-resolution machine learning, particularly in biomedical signals and images, and carry it, of course, to the known context like fetal ECG and ECG itself and so on, but also to these relatively new concepts if possible, to these relatively new contexts if possible, where one might bring together the known methods of signal analysis and machine learning to understand better what could be achieved with traditional systems of wellness. And Professor Rama Jayasundar has kindly agreed to participate from the point of view of the medical expertise. So this is, this is still under consideration. That's what I understand. So I don't think it is appropriate for me to go any farther than this in the description today. I just wanted to give a quick overview, but then we are very open to students who are interested in this kind of work. And I would look forward to good students coming forward for this. So I'll stop here because this is still in a preliminary phase.
Okay. Any question? Any comment? So thanks to Professor Vikram. So now I would like to call Professor Ashutosh from BSB department. Professor Ashutosh, over to you.
Thank you. Just let me share my. I hope it is visible.
Yeah.
Okay, so our project is an NMR AI-based hybrid approach for modeling the progression of type 2 diabetes. And thanks to Koita Center for approving this project. So this is a collaboration between IIT Bombay and KEM Hospital, where Dr. Anurag Leela from KEM Hospital is a clinical partner, and Professor Manjesh Hanwal from IEOR and I from IIT Bombay will be collaborating on this project. So the diabetes, as we know, has become epidemic in India, and cases are on rise. Like in 10 years, we have just 54% of. And with this speed, we are like by 2030, we will be having a huge number of cases, and India will be diabetic capital, unfortunately. So the irony is that the country of yogi is becoming country of rogi. which is not a good sign. So we need to do something about that. And you know, like just little bit of background of diabetes, it starts with a obesity, and it can lead to various kinds of metabolic syndromes, and finally leads to insulin resistance. So there are two types. One is autoimmune disorder, which is type 1 diabetes, and another is because the insulin receptors are not sensitive. So I will not go into detail, but essentially you need to go through insulin therapy in many cases to manage the diabetes and blood glucose sugar. So now there are various factors that contributes to progression of disease. One of them is progress like a protein aggregation. So there is a peptide called amylin that co-secretes with insulin, and that aggregates and that start rupturing the insulin producing beta cell, and that's how insulin producing cells decreases. Other than this protein aggregation, there are various other factors like epigenetic modification, the chronic inflammation and oxidative stress. All these causes the progression of diabetes. So just we started like genesis of this project is we were working on this protein aggregation, a protein called amylin or human islet amyloid polypeptide. We were looking at that, and what we found that recombinant IAPP, when we actually challenge our insulin producing beta cell like INS1E cell, what these guys were doing, that they were lowering the insulin secretion, basal as well as stimulated insulin secretion. So when we went ahead and then put these amyloid fibers produced by HIPP for different time duration and different concentration, and we looked at what actually it does. So control cell looks very healthy, and as we move to these aggregated, like when we put the amyloids, these cells looks not so healthy. So when we did the detailed analysis how they are changing the metabolic pattern, we extracted the metabolites coming out from this INS1E cell and measured the concentration using NMR, and what we found, some of the key critical metabolites like aspartate is changing as we increase the time of exposure with HIPP. So what we find that aspartate is a key metabolites. Like here, if you look at aspartate and oxaloacetate are in equilibrium, and basically aspartate is aneuploidosis. So it actually involved in TCA cycle. So what we understood from this preliminary study, that metabolism is getting reprogrammed, and that is probably happening in type 2 diabetes, that very early, even before it manifested in glucose tolerance test or HbA1c, metabolism is getting reprogrammed. So can we catch that reprogrammed metabolism early on? Because of this aspartate, basically NADH production goes up, which increases the insulin production, and that's how insulin resistance starts appearing. So taking knowledge from this, we thought now let's go and do on real patients. So we collaborated with an endocrinologist, Dr. Anurag Lila from KEM Hospital, and then here we wanted to like take age sex match ratio of about 400 cohort, like a well established diabetes, newly diagnosed diabetes, pre-diabetic, and healthy control as per ADA guidelines, and then taking their serum and doing NMR spectroscopy and mass spectroscopy to find it out what are the metabolites, looking at the patterns, and then combining that. So here is our experimental data coming from NMR spectroscopy as well as mass spectroscopy, and then combining with AI and ML prediction algorithm with of these data, can we early pick up some of these key metabolites that appears in this reprogrammed metabolism. So that's the whole approach. So we want to early prediction of reprogrammed metabolism using experimental data as well as the this AI/ML tools. So at the end, what we want to achieve is a conscious individual who is conscious about his or her inner cosmos, how metabolism is changing early in case of diabetes. So that's our overall goal for this project. So thank you. That's all from my side.
Thank you. Thank you very much, Professor Ashutosh. Any question from audience? I think we don't have any. So thanks to Professor Ashutosh. Now I welcome to Professor Sarthak Gaurav from SOM Department, School of Management. So over to you, Professor Sarthak.
So thanks a lot, Rashmi. Can you all see the screen that I've shared?
Yeah, it is visible.
Very good evening, all of you. So thanks to the Carter Center for Digital Health, that the pilot study that we've been doing with the Health Management Information System of Ministry of Health and Family Welfare, along with the collaboration that we have with UNICEF Maharashtra. So we've been able to get into some of the issues that we see in the context of particularly the health management system data that's been there with the government of India for all these years. So what has been the larger context of our problem identification has been that though regularly data has been collected on around 0.2 million health facilities across the country, across the dimensions of service delivery, which is collected on monthly basis, training of the health facilities or at the health facility levels on a quarterly basis, and infrastructure of these facilities on an annual basis. And we're talking about around or over 300 indicators across both the states, districts, and of late across the sub-district level, because at the state and the district level, it is publicly available data. And at the sub-district level, when I'm talking about sub-district, it is the primary health centers and the sub-centers that is not yet in the public domain. So we realized there are two major problems that need to be addressed. First, though there are a lot of data coming in at high frequency, there's a lack of customized data visualization tool for the policymakers at different levels. So there is a challenge in interpreting the analysis as well as informing the decision makers. And there's also a problem of data validation. So in this context, what our team at IIT Bombay had been doing over the past year is we developed a portal called HMIS Analyzer. So the objective of the analyzer was based on a consensus across faculty and PhD students and the practitioners. We identified 27 key health indicators for a time series ranging from 2017 to 2021 at both the national and the sub-district level and the state levels. So the four categories that we focused on as a part of this analyzer were pregnancy, delivery, child immunization, and childhood diseases related indicators. So the objective of the analyzer was to develop visualization techniques in a format that is suitable both at the meso levels and the field levels. Even the frontline workers sitting in the sub-center and the primary health centers would be able to access this data visualization tools. And the second primary objective was to facilitate monitoring within the government system, be it the national health management programs or any public health management programs. So there should be some sort of monitoring mechanism at the granular level, and there should be feedback going back to the government in order to improve the data quality. So with that objective, this HMIS analyzer, the prototype, some of the sheets of that is being presented here. You'll realize that one of the important prospects of having an analyzer is any policymaker at any granular level would be able to identify a specific manifestation across an indicator category. For instance, pregnancies or deliverables or any child immunization or childhood diseases. So that would be of a first choice that a policymaker might make. And based on that, there will be a template that we have standardized that the indicators appear along with the indicator names. And there are various visualization possibilities that pop up. One is having bar diagrams or bar charts, line graphs, tables, pie charts, and maps for a certain select indicators. For instance, if you see the bar chart protocol that we have developed here, we are given the option of the timeline. You will see that data can be available at a monthly as well as a cumulative scale, and you'll be able to see the variation at the state level as of now. So if you can also look at the top bar, there's an option to toggle to the percentage distributions. Now, in terms of the pie charts, we're also able to present the same for monthly and cumulative, along with the timeline for the states of India, for all these indicators that I mentioned. And also, we're trying to develop customizability of the analytics tools here. So at the top, again, you will see there is a slider where we're letting the policymaker or the user choose the level or the quantiles, or trying to understand in their context what is more important to understand the variations at the state level as of now. And as we progress, we are planning to get down to the sub-district level and the PHC level in Maharashtra in particular. So that will help us develop certain ML algorithm output that could be presented at the front end for particularly forecasting, prediction, and risk modeling across these indicators that we have chosen. And we're planning to extend the analytics particularly to the PHCs and the sub-centers. And IIT Bombay, we've recently set up something called a GIAC hub, which is a Geospatial Information Science and Engineering hub. And there is a data for policy division there. So where the objective is, this HMIS analytics tool that we're developing can be taken to the highest possible level of granularity in that sense. And there is a serious concern about the data quality in HMIS. So based on our interactions with the policymakers, we realize that there is a lot of demand for feedback on the data quality across all the indicators, and certain indicators are very problematic. So another objective of our project here would be trying to give that continuous feedback to the government and to policymakers in terms of where the course corrections can be done. Improvement of the UI is also very important. So we believe as we develop the ML algorithms, as we get into some of the forecasting and prediction of projects, particularly at a district or sub-district level, based on the demands of the policymaker at that level, the user interface could be developed. And we're engaging with that. And we look forward to collaboration from IIT and other places as we move ahead over the next 2 to 3 years as part of this project. Thanks a lot.
So any question from audience? So thank you, Professor Sarthak. Thank you very much. Now I would like to call Professor Abir Day for his research work presentation. Professor Abir Day from CSE department.
Hello, am I audible?
Yeah, you're audible. Would you like to share your screen, Professor Abir?
Yes, I'm trying.
Okay.
Somehow it's just 1 second.
No problem. Take your time.
Can you see my screen?
Yeah.
Okay. Hi, thanks for the invitation. And so our project is on designing predictive model for childhood congenital glaucoma using clinical and genetic data. So this project is with Professor Ganesh Ramakrishnan from CSE IITB and Dr. Shantavi and Dr. Marshall Mani from Shankar Netralaya. Okay. So this is the overview of the proposal. So when I talked with Shankar Netralaya at that point of time, and I was a bit surprised there's still glaucoma for kids. So childhood glaucoma turns out to be a major form of blindness in children, particularly in India, because it turns out that for interfamilial marriage, this is very predominant, particularly in Andhra Pradesh. And and this kind of problem has been largely ignored even by researchers from other domains, particularly from AI or ML or health informatics, which are not from the domain of pure clinical or other way around. So So here there are a lot of interesting challenges from both clinical and engineering viewpoints. So one of the problem is that childhood turns out to be predominantly genetic. Okay, so it is crucial to identify genetic features with clinical features, because it's very difficult to monitor genetic features, randomly from people without looking at symptoms. So, so whenever there is a clinical feature, it's crucial to understand whether there is a childhood glaucoma in the, if there is any symptom or not. So that actually helps in patient counseling or taking precautions. Okay, and the second task is that suppose we detect this kind of this kind of problem, and designing surgical process for kids is very difficult. Okay, so we need to predict the surgical success or the visual prognosis in children. Then only can, so depending on the prediction, we can decide, we can come up with some informed prediction whether we are going to make some kind of surgical procedure, or we can do some operation or not. Okay, and once we do, there are a lot of surgical techniques. So this is kind of will give some hint at exploratory predict the type of surgery that may be kind of beneficial with this kind of using genetic signals. Okay. So it's rare, but not so much rare. So 1 out of 33,000 people in Andhra Pradesh got this kind of disease. So it's a disease of increasing concern because of the numbers and late recognition, and it's prevalent mostly in interfamilial marriage, and the risk factor is very genetic. But at the same point of time, one has to understand that the variants of Indian context have not been explored, especially in terms of prognosis. We don't know the most of the times whether this is a childhood glaucoma. Even if we detect that what kind of variant it is, that's kind of hard explored. So here it is crucial to collect sort of data of genetic data, and that's kind of an important challenge and kind of open challenge. And we don't see much work which kind of leverage this genetic information, primarily because it is might be it's a rare disease. It's not so much prevalent, and it's not very well-known disease, but it's kind of increasing in India, so it has to be kind of seriously taken care. And there is a gap in knowledge of surgical prognosis with various methods in India, including genetic variants associated with BCG. So there is a challenge. There are multiple challenges from the engineering perspective as well. First of all, I believe that there is less data. So one is that data collection is one procedure, but it's not like you go and collect data like in the other domains. So so there are large procedures, and really you have to collect positive and negative cases. So when you collect gene, we have to wait for them, whether there will be a glaucoma, there is a glaucoma or not. So this entire process is very time consuming, and at the same point of time, whether this is a limited data and not so much work, unlabeled examples, whether we can come up with some kind of AI-based mechanism to kind of predict this kind of disease. So we are kind of thinking, or moving towards machine learning at different automation levels. So the data is kind of, I believe, very small in numbers. So it's important to understand that even a sophisticated machine learning model cannot work to its fullest potential in these situations. So I think it is crucial to develop machine learning models at this limited or kind of cold start scenario that will take human in the loop. So the goal is to develop these models that are optimized to operate at different automation levels. So we are not going to fully deploy machine learning model or planning to deploy machine learning model just like we do in other scenarios, which is now ready to deploy, for example, NLP or image processing task. Okay, so we want to exercise a bit of caution here. So we will employ machine learning methods as well as human, and the task is to define a meta algorithm that will kind of partition the data in spaces where machine will take care of one part and the human will take care of one part. And and the task is that there is some samples perhaps which is human that need human interventions, and machine cannot really understand. And since it's a very rare disease and the prognosis is subject to early detection, it's important to come with very accurate prediction. It's important to work together and at simultaneously scale the prediction tasks. So for example, if we get like a lot of data, for example, even 1,000 data, we cannot just process this quickly. So we want to have a cheap machine learning model. We can quickly say that, oh, these are the predictions, or these are the instances that require human intervention, and then the doctors will see. Otherwise, we'll completely rely on machines. So it will be a human machine collaboration model based on which we are going to decide on this. So we are looking at one dual degree student and one PhD student for this, and yeah, so we have a strong track record of publishing papers in top tier ML venues, and Shankar Netralaya is a top institute in terms of ophthalmology. So we believe that there will be high impact results that are coming out of this proposal. So anyone who likes to discuss and want to participate, I will. Thank you. So, yeah, any question?
Any question from audience? So I think we don't have any. So let's thanks to Professor Abir for such a one. We have one question from Abu. Yeah, Abu, please go ahead.
So just the biophysics is the same field or the same subject related to these things, or mechanical biology is somewhat related to this?
So I could not understand the point. Sorry. Hello.
Abu, your voice was breaking.
Can you hear me clearly now?
Yes.
Hello.
So can you repeat? Yes.
The biophysics or the mechanical biology is the part related to this topic only? Does this thing has somewhat related to that things? Mechanical biology or biophysics?
No.
Okay.
Any other question? So I think we don't have any questions. So let's thanks to Professor Abir for such a wonderful talk. So next, and that is the last talk of this session. So that will be presented by Professor Sanjeeva, but he is not present in this meeting right away because he is busy in some other track over there. So we have one recorded copy of his research work. So I will play that. Just wait for a moment. Is my screen visible?
Yes, ma'am.
Yeah.
Good evening, everyone.
Audio is clear?
Yes, sir.
Good evening, everyone.
Yes.
First of all, let me
I'm sorry, there is some problem in my system. I'm retrying. Please wait for a moment.
Good evening, everyone. First of all, let me thank Mr. Ganesh for giving this opportunity to present our proposed project, which we are going to do under KCDH. So the breast cancer does not require much introduction, despite a lot of advancement being made. Still, it is one of the most prevalent type of cancer which we see in Indian women, and especially triple negative breast cancer is very aggressive tumor type. So idea for this project is, can we identify some protein biomarkers and the protein interaction network, and then trying to narrow down those targets or the potential biomarkers using machine learning approaches. For doing this project, I am Sanjeev Srivastava from Department of Biosciences and Bioengineering at IIT Bombay. And the co-PI of this project is Dr. Sudeep Gupta, Director of ACTREC, one of the most renowned clinician working in the breast. Good evening, everyone. Good evening, everyone. First of all, let me thank Mr. Ganesh for giving this opportunity to present our proposed project, which we are going to do under KCDH. So the breast cancer does not require much introduction, despite a lot of advancement being made. Still, it is one of the most prevalent type of cancer which we see in Indian women, and especially triple negative breast cancer is very aggressive tumor type. So idea for this project is, can we identify some protein biomarkers and the protein interaction network, and then trying to narrow down those targets or the potential biomarkers using machine learning approaches. For doing this project, I am Sanjeev Srivastava from Department of Biosciences and Bioengineering at IIT Bombay. And the co-PI of this project is Dr. Sudeep Gupta, Director of ACTREC, one of the most renowned clinician working in the breast cancer area from Tata Memorial Center. We thought to contribute together in this project. And following objectives have been defined for this project, which we are going to start soon. To first look at the disease pathobiology of these triple negative breast cancer women, and trying to generate a lot of actual patient data, which is, despite so much advancement being made, still we are lacking much of the actual patient proteomics data from Indian population. So can we look at triple negative breast cancer women and take their tumor tissue, extract the entire proteome from that, and using advanced proteomic technology like mass spectrometers to first identify all of those protein, and then look at the image classification to find out the best potential classifiers using machine learning approaches between tumor and the normal samples. Following the first objective, then we would like to validate our identified novel candidates. For doing so, we will be using multiple approaches of traditional known technologies in the clinics, as well as some of the recent mass spectrometry-based approaches like multiple election monitoring and parallel election monitoring. So this is how the overview of project looks like. First, the triple negative breast cancer patient samples will be collected at Tata Memorial Center. From the same tumor type, surrounding to that, there is a peripheral normal tissue. So those peritumoral tissue will be the right control for these kind of tumor samples to be compared. So we will have this paired analysis for each individual. And either we will use the fresh frozen tissue or the FFP tissue blocks. We'll extract the protein and digest those to make peptides, analyze them using mass spectrometers to identify the protein expression, post-transition modification, do a lot of big data analysis, then look at the principal component analysis and pathway enrichment analysis. Then we would like to move on further to build the models from this kind of data and use the selected biomarker candidates based on the machine learning approaches for the further performance evaluation. We would then like to validate these targets using multiple approaches, including the one which is shown here, which is based on a triple quadrupole based mass spectrometer known as multiple direction monitoring or the targeted proteomics approach for validating the specific biomarkers. So what we are proposing to perform in this particular project is essentially take 50 paired triple negative breast cancer patient samples. Those will be collected and characterized. All the clinical details will be documented at Tata Memorial Center in Navi Mumbai. And then further sample processing and the big data analysis will be performed at IIT Bombay. But both the teams will be continuously discussing and being involved into identifying the most meaningful candidate biomarkers from this work. So novelty of this project is that, of course, this is one of the first comprehensive proteomic analysis of the triple negative breast cancer samples from the paired tumor tissue and the controls, which we are very optimistic that will reveal some of the crucial signaling networks which is involved in the TNBCs. And once we do this, we would also like to develop some of the models which may be used to even predict the tumor-specific signaling networks in the TNBC patients. So this is the timeline which we have proposed for doing this project, given that our teams have already been working together for various projects with Dr. Sudhir Gupta and our team. We are quite optimistic that we should be able to achieve this timeline, which is proposed here. And the deliverables will be that we would like to identify the potential protein biomarker candidates from the triple negative breast cancer patient samples, use various big data analysis approaches to identify the meaningful candidates, use machine learning approaches to find the classifiers, and then use again experimental technologies to validate those targets. This could be one of the very novel projects where we are actually starting from the actual patient samples, trying to generate the meaningful data, not we are just relying on obtaining data from other sources and trying to make sense of that, but rather we generate all the data from the actual Indian patients with their matched paired samples, which is one of the rare things to really obtain. And that will really lead us to some very important findings for the Indian patients, because that type of data is still lacking. We are very much still relying on a lot of data available from the Caucasian and other world populations. So towards this, we have already started working with Dr. Gupta's team to at least see, even when we take the needle biopsies of these tumor tissue, can we still do proteomics on those? And we looked at how low we can go. In a good way of doing proteomics, you'd like to go maybe at least 25 to 30 milligram of tumor tissue. But we have now optimized that we can go even less than 5 milligram of tissue to really do proteomics, and that has given a sufficient good protein yield, which you can see here. We have run those samples on the SDS page to look at the protein profile, which look pretty decent. And then we have run in the mass spec to obtain the protein overall patterns of the chromatogram of the mass spectrometer. The study has already been approved with the Institute Ethics Committee of IIT Bombay and with the Tata Memorial Actrac Center. A lot of work already goes on to doing this part, and MOU is being drafted and being, in process of signing. So as the biosafety approval is being, considered, we have already submitted. So this is where we are on this project. We are very much thankful for Koita Center for Digital Health for supporting this project and providing the seed fund to start this project. And once we are able to deliver the pilot scale study, then of course we would like to expand it to much larger number of patients to really take some of these leads forward for the successful clinical translation. Thank you very much, everyone. Given that I'm also conducting as a convener this conference TRIM, there are multiple parallel sessions going on. So I'm not available personally right now to you, but if you have any suggestions, comments for me, please do just email me on sanjeeva@itb.ac.in. Thank you very much for your attention.
Thank you all colleagues. for your time, for your patient presentation as well as patient listening. Um, Rashmi, we seem to have concluded sooner than planned, right?
Yes, yes.
Okay, so if any colleague would like, I think we all of us try to rush and stick to the 10 minutes time given or less than that to accommodate. But I'm first of all grateful to Professor Ashutosh Kumar who helped chair the session. Also very grateful to all the colleagues who presented. If there's anything you would like to speak or ask each other, uh, the floor is open. Also grateful to Professor Nitish Thakur who was here for a long time, and then Professor Bhramar Mukherjee has joined us. She will be speaking next. Professor Bhramar will be also keen to hear from you. Probably you heard a couple of project spotlight presentations. So the floor is open. Like to hear from anyone who would like to speak. Also, just to set the context, these were like spotlight presentations on work that faculty members had been doing here already, but which have now got the next level of support through a seed grant at KCDH. So these were like spotlight presentations where a combination of the work they've been doing and how they're going to take things forward using the seed grant, right? That was presented. Though work has not really begun on the seed granted proposal itself. Yeah. Professor Bhramar, would you like to share anything?
No, of course, I just heard a couple of presentations, and it's just wonderful to see the dream of digital health and nanomedicine and translation of technology into medicine and healthcare being realized. And we all know this is, hard process. Our discoveries in the labs take a long time to reach the patient. And I can tell you, in my 25 years of career, one or two maybe are reaching a patient, and that's very lucky. And we spend all our life doing science, but to see the translation potential and to really be able to help a patient is the most meaningful thing. And so it's wonderful to see that conversation and that dialogue, and of course the KCDH taking a leadership role in propagating that spirit at IIT Bombay and also nationwide.
Thank you, Professor Bhramar, for the words of encouragement as well as caution, I would say. I think in your words, you also cautioned us against being impatient in this process, because from the lab to the practice, the operational setting could be a hard grind.
Yeah. Yeah, it's a long journey from bench to bedside, and we all know that. And science is supposed to be hard. It is not supposed to be every discovery makes it to the patient care. So we have to be very patient, but we have to keep on working on that dream.
Thank you. Thank you, Professor Bhramar. If there's anyone else would like to comment, please feel free. Otherwise, we are super excited to hear Professor Bhramar speak next. So, anyone else?
I don't think I can share my slides.
We will just let you be the presenter. Are you able to present now? Can you share now?
No. It says you are okay. I think that takes a while. Yeah.
Professor Pramod Pangikar will be chairing the next few sessions. Is that correct, Rashmi?
Yeah.
Okay.
He is not doing it. I have called him.
Yeah, he's joining.
He's
joining. Can you see my screen?
Yes, very clearly.
Okay. And my slides?
Yes, both.
Okay, all right. Yeah, I'm happy to start when you are ready.
Rashmi, would you like to advise? Okay. Yeah. So, Dr. Bhramar, maybe a couple minutes. Um, this session
Yeah,
got
no worries.
over sooner. It's, this interesting that most of our sessions are today are getting over sooner than planned. um, I know that doctors are hard pressed for time, and maybe their collaborators here at IIT Bombay are also realizing the value of time.
Professor Ganesh and team, I just want to congratulate. Can you hear me? This is Barnali.
Yes,
So
Dr.
I
Barnali.
heard all the yes, I heard all the presentations, and I really appreciate the efforts and for Quetta Center of Digital Health, and many congratulations for taking this leadership role in digital health transformation in India.
Thank you very much. We take it as encouragement, but I think the honestly the lot of the wishes and congratulations are for the digital health partners, the doctors who have patiently sat with collaborators here, articulating problems and identifying the potential solution between two disciplines which are hardly met in India, right at the ministry level. We have Ministry of Health and
Absolutely, absolutely.
Ministry of Education, I mean Human Resource Development, which are two different silos. So I'm really excited and grateful that all of you sat together and wrote these proposals. So I would say it's a big milestone. Thanks, Dr. Vanali.
Thank you.
I think uh, he's joined already. Okay, I can see. Has Pramod joined? Smita? We can probably get started then. Pramod has joined. Since we are waiting for a few minutes for Professor Pramod, Dr. Bhramar, one question I have for you. Since your talk is about electronic health records, it's a more detailed question. How has been the drive for open source EHR? How has it been received in the US? I mean, in India, the challenge we face with open source is that you need solution providers, even with open source software, right? On the other hand, the private partners can deal with the problem end to end, but then issues like interoperability and all those creep up, and also the issue of serving the marginalized, right? The really small hospitals, which you really won't buy an expensive EMR system for 50 beds. So how has this open source been received in the US? I'm very curious.
Yeah, so I think the problems are very similar in the United States as well, that it is a selection bias. People who have good established electronic health records, in particular, Epic is very popular. But if you go to underserved communities, even federally qualified health centers, they do not have much of an electronic health record. So at University of Michigan, and I'm going to talk about this problem as we are trying to diversify our cohort and make sure that this is a nationally representative sample, it's really, really difficult if you have such disintegrated electronic health record systems like we do in the United States as well. So I think that it is very restricted right now for Kaiser Permanente. So some of the companies which are vendors of data have lots and lots of amassed a lot of electronic health records, but again, it's access to healthcare. It's a very selective population. Where can you generalize your results to? That's something that you really, really have to think hard, and that's one topic that we have been working a lot on. But I do think that if you even look at COVID, the countries which have made real contribution are UK, Israel, Denmark, where they have population-based registries and connected, integrated health records, right? So one from the time you get vaccinated to your breakthrough infection to your clinical outcome, these are all linked in the same system. So you do not have to go that extra mile so that different kinds of databases are in silos and they don't cross-talk with each other. And in the United States also, it's not the ideal system at all. These disintegrated data systems are not really helpful to respond particularly to an acute health crisis like the one that we are experiencing right now. So in Israel, it's very interesting that they have Clalit Health Services, which is a insurance company, but it has 90% coverage. And they have always been very proactive in terms of using data for research. And that's why they could tell us like the waning effect of the vaccine, the need for the boosted dose. It's a small country as well, but still having really comprehensive capture of all the health encounters of an individual is really, really important to do anything population based. You're absolutely right. What we are doing is just like tip of the iceberg and wrinkled with many, many problems.
Thanks, Professor Prabha. That was very, I would say, very nicely summarized and kind of echoes some of the observations we have in India.
Yeah.
Probably now, without further ado, can request Professor Pramod to chair the next session, and we are keen to hear you.
Thank you.
Professor Pramod.
Yeah, thank you. Thank you, Dr. Mukherjee, for joining. I understand, Ganesh, that there is an introductory video about the speaker. So we can start.
May I request to Professor Bhramar, can you please stop your screen sharing so that I can share my screen?
Okay. Oh, I didn't know that. Sorry.
Thank you.
I think I stopped sharing.
Yeah. My screen is visible. some problems.
Some of the perils of online conferences.
So, Mr. Pramod, I would like to request you please go ahead and drive the session. Professor Pramod.
Professor Pramod, you can get started. Looks like there's some problem.
Yeah. So I was relying on the video, and therefore, Dr. Mukherjee, I must apologize that I don't have a written introduction with me. But let me say that Dr. Mukherjee is a renowned professor in the Department of Biostatistics at University of Michigan. Most importantly, she is on the advisory board of the Koita Center for Digital Health, KCDH. KCDH is a brand new center at IIT Bombay, focusing on digitization of health using artificial intelligence, machine learning, and so on. We have seen your blogs, and we have heard your views on TV, on NDTV, and so on. So most of the people who are in this session, they know about you quite a bit. So without further delay, I request you to start your lecture, and we'll take questions at the end.
Yeah, thank you so much, and thanks everyone. Can you see my slides? Okay.
Yes, we can.
Okay. All right. So as it was mentioned that I have been working a lot on COVID and particularly COVID modeling in India, but today I'm going to take some time to discuss my research on integrating electronic health records with several other data sources at Michigan and building a source for digital health research. And the resource is not just for me, but for generations of researchers at University of Michigan and beyond. But before I begin, I really want to congratulate IIT Bombay, the collaboration between the Department of Biosciences and Bioengineering and the Quetta Center for Digital Health. There is this dream of using data and technology to improve patient care and human health that we all share. And the intersection of math and engineering and science with medicine, and where people come together, describe the healthcare challenges, and then use technology to solve those challenges has been one of the most fascinating journeys of my life. As a statistician, really trained in pure math in Indian Statistical Institute, I never thought that I would be a part of precision health at University of Michigan. I'll be leading cancer control and population sciences at a cancer center. So it has sort of feels like a fairy tale for me as a math nerd trying to really solve problems in medicine. But this has been the most gratifying journey of my life. So I want to really congratulate you on that. I also want to pay my respect to Professor Banerjee. And this conference, I realize, is in her honor. And of course, she shared the same dream of taking science and innovation to make a difference for inclusive healthcare accessible to all. And we have a lot of important role to play in this process at a national level and at an international level. And I really feel very sorry that we lost such an eminent and promising researcher to post-COVID complications. When we count the deaths of COVID, we really cannot quantify the losses due to COVID. And I just want to take a moment for all of us to think about all the dear ones that we have lost and all over the world. So she had a dream of realizing nanomedicine and translating technology into practice. And when I began at University of Michigan about 15 years ago, which sometimes in life you have to work on projects which are not going to bear immediate results. And that's very hard for junior faculty because we want to see immediate payoffs in terms of our research. But sometimes you have to think about legacy and you have to think about helping others and creating bigger dreams and bigger resources. And that's what this project is about. And I just want to make 2 points, how we work towards growing a integrated digital health ecosystem at Michigan with different types of data. And then when COVID hit, how we use these data resources using the EHR data to write some important papers and observations about Michigan residents during the time of COVID. But before I begin, I really want to thank my team. My team is comprised of geneticists, statisticians, epidemiologists, because you cannot really do this alone. One person or the skill sets that we are trained with is not enough. And that's why I'm really excited for the Quetta Center, because you are bringing many minds from many fields and many disciplines together to sit at a table and to discuss a problem. And everybody has their own way to looking at the problem and own tool sets to contribute to the problem. So we started about 10 years ago. And we are supported just like, Quetta Center is through the generous donation of many important donors as well as support from the institution. We started with support from the Provost's office at University of Michigan. It was about $100 million investment, thinking about creating a data resource that is not just one person's data resource. It's not for a prostate cancer investigator. It's not for a cardiovascular researcher. It is for everybody on campus who can use this data resource as an accelerator and incubator for their ideas. So this database could be used to validate some findings that they have in their own study, but also to generate new hypotheses in an agnostic way. And the ultimate goal was that once we create this resource, people will be able to apply for funding, garner extramural resources in order to keep this legacy going on. And that was in 2012 when we started going to patient clinics. And in particular, when patients were waiting for surgery, we went and asked for their consent to participate in this longitudinal biorepository, which we call the Michigan Genomics Initiative. And this Michigan Genomics Initiative asked the participants to get their consent to connect their electronic health information, which are generated every time you see a healthcare provider at Michigan, with biospecimens that we collected, and in particular, in this case, blood samples, so that we can do germline genotyping. And so and this consent was really the progressive and game-changing transformative piece of this study, because we also asked the patients that, well, you are giving us permission to connect your electronic health records to your genetics, but can we also possibly link this database to other things which can be linked through your social security number, which is like the Aadhaar card number in India. So and that was huge. And I will tell you, people really agreed to give this kind of data. We hear a lot about privacy and confidentiality in healthcare, but people are still willing to contribute to their data to improve healthcare of their next generation. So when we asked for this consent, we also got recontact permission. So that enabled us that given this data, if there is anything, a new issue, we could invite these participants to a new study, or if we find something clinically that is meaningful for their personal health care, we can get back to them. So there are many, many big data resources in the world, in particular UK Biobank, which is a very democratized big data source where you have 500,000 people with imaging data, with genetics data, with health smart device data, lots and lots of different domains of data accessible to everybody in the world. But Michigan Genomics Initiative is very close to my heart. It's very close to my heart because I know this physician, I know this participant. And so the opportunity of taking something, a scientific finding or a clinical finding or a data finding, taking that and getting it back to the community was very motivating and empowering and inspiring for all of us working on this project. So Michigan Genomics Initiative, or MGI, I'm going to say is definitely big data. It has many medical encounters digitized, and then genetic data. And after imputation, we are about at 21 million genetic markers across the human genome, integrated with many medical records. But as you will soon realize that an individual or a participant's health existence is not really codified through medical phenotype and genetics, so we collected many other domains of data. And this is something I want to really emphasize. If somebody is trying to create these data repositories or biobanks, it's extremely important to collect data on behavior and lifestyle factors, environmental factors, social factors, because this constitutes the tapestry of our existence, not just our health records and genetics. On a subsample of people, we also have Apple Watch data in a collaborative study with Apple. So then I felt that while using this data, it was not enough to just have the medical diagnosis at each encounter codified as an ICD or International Classification of Disease Code. It was important to have questionnaire data or survey data, and we launched an epidemiology questionnaire study on top of this layered architecture of different domains of the data that we showed you. And then physicians, if somebody is interested in cancer, so we provide this broad T-shaped umbrella of data to everyone. We do not really need to ask a patient 100 times during their interaction that their smoking behavior, their alcohol consumption. We just can ask in a same data definition these questions. So these questions are available for everyone, but if an investigator is interested in mental health or cancer or pain outcomes, then they have their own deep dive questionnaire into that specific disease domain. So this is our thinking, that we'll have lots and lots of things measured on many people, but then we'll have the opportunity to deep dive into a particular disease area. For me, for example, GI related cancer or women's cancer. So what we have created over the last 10 years is this database, which has genetics, electronic health records, but also I told you that we could connect through social security number any medical claims or pharmacy claim data, national death index, any kind of outpatient EMR. And then also, because we had geocoded residence information, that's where data modeling tools come in. Because we had the residence information varying over time, we could connect that to get some ambient measures of air pollution. We could get census tract variable on neighborhood characteristics. Do they live in a neighborhood which has access to healthy fruit and vegetable stores? What is the average income in that neighborhood? So we could collect a lot of ecological level variables based on their geocoded residence information. So at the end of the day, over 10 years, I really have a dream data set. And when I graduated in 2001, I never imagined that from my desktop, I'll be able to access data on 100,000 people on so many millions of records. And that dream has been possible through information technology advances, which has been really, truly a revolution in our lifetime. So when we have all of this, when an acute public health crisis like COVID hits, then we can layer this data with additional COVID data. And that's why you have heard me complaining a lot on television about the quality of data. We do not have integrated health systems, and the United States is far from being perfect. And I'll give you some examples which I think have been great role models. If you have all of this data in Michigan EHR, at least that we were able to layer it with vaccination data, COVID severity, who are getting hospitalized, who are experiencing long COVID symptoms, and then we are able to roll out several surveys in the beginning part. We also realized that during COVID, obviously surgery nobody, like a recruiter was not allowed into the healthcare spaces, but we still did not give up. We actually recruited patients by phone and sent them saliva kits so that they could send their sample back. And you can see that it's important to continue our research in spite of the difficulties that the current times are posing to us. And then the epidemiologic study was also rolled out during COVID. And it is amazing that this was a period where people actually like to do surveys, and particularly about health. So our completion rates on surveys were very high. Just think about it, during lockdown and stay at home, we are playing with our phones anyway. So we are more contributing to the process of survey research. And that was a great time to roll out this survey. We also rolled out several surveys on COVID. Many of you know that worldwide, the Facebook and many other organizations have done repeated surveys on COVID-related symptoms. But for us, because we had an engaged participant community, when in May to June of 2020, in the very early days of COVID, we could write papers which are truly focused to the people we serve in our catchment about Michigan residents. What are their risk perceptions? What are they feeling about community exposure? What kind of symptoms are leading to severe COVID outcomes? We did not know much about COVID at that time. We desperately needed to gather more information and more data. And in the first few phases, we were really concerned about the bias in the data, because if you remember, tests were not abundantly available, so very few people could get tested. So before you analyze the data, it is very important to understand who is in your sample. Only people who got tested could be diagnosed or have a positive COVID positive record in the electronic health records. So we really tried to understand who is getting these repeated tests for COVID, RT-PCR test, and then later on rapid antigen test, but also to understand the pattern in terms of serological testing or antibodies that are present. And this is pre and post vaccination antibodies have sort of a different meaning, but we continuously model the data coming out of the EHR and try to get that information out there for physicians as well as for Michigan residents. So electronic health record data, it is exciting. It has a lot of like spurious association, lot of garbage information in it, and you have to be very careful analyzing it. But you can see that it has an immediacy that what is happening, what is the action in the medical world. And you can see that in real time, and that was the exciting part of this data. So what I'm showing you on this figure is a figure of what is the proportion of people having antibodies starting from April of 2020 and then after vaccination started. Many times people try to use this as seroprevalence as a estimate of how many people in the population actually had COVID, because we know that there are many COVID infection, many asymptomatic infections, but then you have to account for who is getting tested. But what you can see, in spite of the bias, that there has been a clear change in terms of the proportion of reds and greens before and after vaccination. And it was very exciting to see when we, if you remember the first days, the excitement of getting vaccinated, that actually the proportion of positive antibodies was actually the fraction of red is increasing. And you can, so what I'm trying to say is that on an absolute scale, there are many anomalies in this data, but on a relative scale, you can still pick up some signals. And that's my biggest lesson, that don't give up, look at the data, use the best tools in your arsenal to make it useful and to make it useful for people. So electronic health record data, and as it was mentioned, it's very porous, it's very spotty. Physicians actually do not like electronic health records. My clinician friend says that when I'm actually talking to a patient, having to input all of these codes at the same time simultaneously in their medical records is very challenging. This data set was, this system or the EPIC system that we use was mostly designed for billing purposes so that the hospital administrators can send you a bill. I recently realized that lawyers also look at EHR to find out if any medical malpractice was done. Oh, you were supposed to get this medicine at 6:37 p.m. and you didn't get it, things of that nature. But data scientists and informaticians like us really like imperfect data, because then we can show our skill sets to say we harmonize the data, we make it to use so that you can translate the findings into knowledge and in sometimes, rarely, into actionable knowledge. So the challenges with electronic health record data is that the pros are that patients are coming to healthcare system, so you can definitely get the data. So in 10 years, we have a cohort of 100,000 people. You also have longitudinal tracking naturally, because people who are coming for their patient care, primary care at University of Michigan, many of them have been coming there for years. So you have their trajectory. you also have this callback potential of really making a difference. If I find that somebody has a very high polygenic risk score for colorectal cancer, maybe I'll do that colonoscopy more often, or maybe I'll do one type of screening if I knew that this person was at a high genetic risk. So there is that real translation potential, which is really exciting. But the cons are, who is in your study? There is no study design because these databases were not designed for population-based research. So it's a very selection bias prone database. And then when do you see any electronic health records? Obviously, you don't get a blood test done, at least in the United States. The insurance is not going to pay for it unless you have symptoms. So the observation process, when you see these observations, are extremely informative and biased, and you cannot just think that these are random observations that you are gathering on random participants. So that ascertainment bias really makes it difficult to generalize the result until you work very, very hard. So when we teach statistics, we go into our classroom and we ask students that when you think about translating from statistics to parameter or sample to population, you have to ask these questions: who is in my study and what is the target population of inference? And many times I'm seeing that people are getting very jazzed by machine learning and neural networks and all of these deep learning methods, but not thinking about these fundamental questions about what is the population that is being represented in a data set that you gathered from Google or Twitter sentiment analysis, or you are doing electronic health record analysis or medical claims analysis. Who is in your population? So in Michigan, it is a genomics initiative. It's a huge problem because if you remember, I said that we recruit most patients when they're waiting for surgery. And who undergoes surgery? It's not a representative of the whole population. And if you look at the data, you actually see that roughly 50% of patients actually have a cancer diagnosis. So obviously that's not the lifetime prevalence of cancer in Michigan population. This is enriched for cancer. And you'll see a lot of enrichment for other diseases as well. But what is really startling to me that 75 to 80% of the people that we approach actually give consent to use of all of their data, linked through social security number, callback potential, participate in future studies. And you know, when we talk to these participants in community engagement studios, they tell us, we believe University of Michigan researchers, we believe that they are going to use our data to do something good. So this faith in scientists is extremely important in people, and we have to honor that faith as we manage the data, analyze the data. We have to really honor the participants. So what I'm trying to say that if you collect data like this, for example, in Tata Memorial Cancer Center, for example, then you have to think about who is your patient population. And are you trying to generalize the result to a population who are approached for consent from which you drew your sample, or you want to do something bigger? Do you want to go to Michigan medicine entire population, not just the perioperative population? Do you want to talk about the state of Michigan? Do you want to talk about United States? So in order to do that change, to make that extension, you really have to work hard. You have to work hard to understand how does your population that you have, that you are analyzing, differ from the Michigan medicine population or the United States population. And there are ways in which you can calibrate your estimates, but for that you need information on your external population so that you can map. So our dream for this database is really that Michigan investigators have access to a very rich data set with large N or a sample size and large P, different domains of variable. And many people, it's not somebody's property. Everybody on campus, if they have an idea, they can use this database. And that's why the social and the environmental components of the database becomes very, very important. And as we see new crises emerge, we can pivot this existing system to address emerging challenges. But at the same time, we should be really aware of the pitfalls that science is hard. We cannot just take and amass data and analyze it mindlessly. So I'd just like to spend the last 5 minutes talking about how we used it for COVID-19 research. I already showed you that we are very interested in modeling who got tested, serological prevalence, and so on. As I was mentioning, that data is very important, integrated data systems. Some of the pioneering groundbreaking papers in COVID during COVID times have come from the United Kingdom, Israel, Denmark. All of these countries have very good population-based registry or the national health system and very active and agile official statistics department. And so to have this really enabled them to talk about vaccine effectiveness. If I ask in India that compared to like there you have 2 or 3 vaccines rolled out, then what is the rate of breakthrough infections? How does it differ between men and women? This simple basic data is not there. We do not have even disaggregated age and sex level data for mortality in India. So having integrated databases where secure databases are not siloed, where the testing database talks to the COWIN database, talks to the clinical outcome database, so that you can tell me that what are the rates of breakthrough infection between, Covishield and other vaccines, right? So I, as a consumer, I'm entitled to know this information in a real-time way to decide on my booster. So for COVID, because we had done all of this machinery, we could fit models and just let us, for example, take a logistic regression model. We are trying to model COVID-related outcomes, for example, severity in COVID, hospitalization, ICU rates in COVID, as a function of what is influencing this. Is it race? Is it socioeconomic status? Is it pre-existing comorbidities? Are people with type 2 diabetes or heart disease at a higher risk of COVID-related severities and deaths? If you have to remember, in the beginning part, we did not know much. We only had the data at hand. And from the very beginning, we were recognizing that the loss of COVID, that the distribution of loss of COVID is not uniform across race ethnic groups. There are people who still do not have access to tests and antivirals. As we see that COVID is nothing, we are really talking about, again, a very selective population. So our group was one of the first few groups who wrote this paper characterizing that Blacks were at a much higher risk of COVID-related complications, and that disparity has not been washed away over time. What do I mean? Like in March to June of 2020, in our initial analysis, we saw that Blacks have a higher odds ratio of ICU admission and mortality compared to whites in our database. And if you adjust for certain confounders, for example, socioeconomic status, neighborhood access, then this difference actually diminishes, but still it persists. But then when we looked at January to May of 2021, 1 year later, what we saw that the risk of hospitalization, the risk of ICU admission has gone down. So you can see the height of the bars from the left side to the right side has gone down substantially. But it has not gone down at the same rate for Blacks compared to whites. If anything, the disparity on a relative scale is more acute. It is important to use data to make such social commentaries, to understand and to really underline the inequities in health. And I think scientists can play a huge role in making inclusive healthcare possible. And similarly, we did really machine learning data agnostic searches because we did not know any better who is at risk for COVID-related complication. So again, you have to put these results in the light of we did not know much. We are just taking a blind look at EHR to see who is getting hospitalized. And we see that if you were at high risk for pneumonia or respiratory diseases, of course, hypertension, renal disease, then you are at higher risk of hospitalization. And these risk factors actually differ across whites and across Blacks. And it's important to really characterize such subgroup specific effects. And then we wrote this paper and make this tool accessible and updated our data so that physicians could look at real time. If you had some diagnosis in your past electronic health records, maybe you should be under higher watch or alert for COVID-related complication. So later on, there have been many papers. But to do this in real time when this crisis is going on really takes this infrastructure that you're building with KCDH, which is going to pay dividends in the future to changing healthcare. So right now, we are working on many projects using the EHR. Particularly, I'm very interested in long COVID. Who are the COVID long haulers and what are they experiencing? And we also are looking at how do we think about missing data in this electronic health record? As I told you that you are seeing certain tests because you have certain symptoms. How do we really debias the data from those design issues? And one thing which is really important is to think about the effectiveness of boosters. For the next 2 years, we'll probably take our 4th dose or 5th dose. Are we ready? When should we time it? Like here, you can see the dashed line is the case curve, and in the background in different colors are the variant distribution. And we know that the vaccine effectiveness changes with respect to the variants. And then how do we quantify if a booster is effective for a person? And what are the optimal time windows of getting boosted? These are very important questions. But if you do not have the data, which has your vaccination, related with your covariates, related with your COVID outcomes, you are never going to be able to do this research. So infrastructure is really at the heart of brilliance. And similarly, I think that, missing data, I see a lot of missing data work being done by computer scientists and informaticians without paying attention to the basic fundamentals of informative missingness. And I do think that there was a recent JAMA piece by my colleagues saying that really when you do EHR-based research, you have to really assess the missing data patterns, because when you see an observation, it's actually very informative. So I think that as a summary of point 2, I just want to mention that it was very important that we had the right tools at the right time, and also right team. Statisticians and in general quantitative data scientists have a lot to offer in major public health and healthcare issues with their nimble data analysis. Working with electronic health record data was fun, but it could be very frustrating at during some points of time. But you have to bear through it. You have to persevere. That's our fundamental lesson in doing scientific research. But it's fascinating in the end when you see things that make sense emerging out of this very haphazard, very messy database. So I just want to conclude by saying that I'm a data dreamer, but I'm not the only one. Many people have joined us. I run a summer program where we have trained about 250 students. They come and destroy the electronic health record database, crash the system with terabytes of data, but they're fearless, but they're my hope. If I ever dreamed of a data revolution, this is my army that I'm training. And I hope that along with the mission of creating infrastructure, you never forget the next generation, which has been a real strength of IITs in general to produce the best and really bring people together. And I know that Professor Banerjee was also a very keen mentor and very devoted to her students and trainees. And that's the main legacy of those of us who are in education, not just research, really building strength through the next generation. With that, I just want to thank you for your attention and also thank each and every participant of Michigan Genomics Initiative, without whose contribution and sharing of data, this research would never have been possible. Thanks so much.
Thank you, Dr. Mukherjee. I know that the video didn't play well in the beginning, the introductory video, but the students have, worked hard to prepare the video. So we are going to try it one more time. Is that okay, Ganesh?
Absolutely. If Dr. Bhramar is fine.
Yeah.
Ladies and gentlemen, we are delighted to have with us Professor Bhramar Mukherjee, who joins us from University of Michigan. Professor Mukherjee is a John D. Calford Collegiate Professor and Chair at the Department of Biosciences, Professor at the Department of Epidemiology and Global Public Health at University of Michigan, School of Public Health. She is also a research professor and core faculty member at Michigan Institute of Data Science, University of Michigan. She has completed her PhD in statistics from Purdue University in 2001. Professor Mukherjee and her team have been modeling the SARS-CoV-2 virus trajectory in India for the last 1 year. Her research interests include statistical methods for analysis of electronic health records, studies of gene-environment interaction, Bayesian methods, shrinkage estimation, analysis of multiple pollutants. Recently, she has been interested in shrinkage estimation and prediction using diverse heterogeneous data sources. Ladies and gentlemen, please join me in welcoming Professor Bhramar Mukherjee.
I'm sorry, Professor Bhramar, for this technical error from our side. So what I guess is that that PPT was containing heavy video files, so that is why that got stuck all of a sudden. So I'm very sorry for that.
Yeah, so we can open the floor for questions. If people can raise their hands, then we can go in that order. Yeah, I see Professor Nitish Thakor has raised his hand. You have a question?
Yes, sure. This is great, very informative. And in fact, the last point about long COVID is going to probably play an increasing role, as also these booster shots, take them or not to take them with new variants. Do you have any opinion on whether it's even possible to build predictive models? I mean, because past may not apply to new variant, and so what's the biostatistics of these kind of predictive models that are going ahead?
Yeah, so this is very interesting question, because with the different variants, we are sort of at a different risk profile. So what we have seen so far, and from not just my work but review of the literature, is that definitely post-vaccination, and also like it's very hard to tease apart like the effect of the variant and the vaccination, because most samples we have is vaccinated and the variant has also changed. So what we see is definitely that the probability of getting past post-vaccination have gone down. But once you get it, the duration and the complaints and the suffering is very similar, and the symptoms that you have is very similar to the past. So we just published a paper yesterday in Journal of Infectious Diseases that globally, all of the studies that have come out in the last 2 years, the prevalence of PAS in COVID positive patients is about 40%. And for hospitalized patients who had to be hospitalized, of those conditional on that, it's about 50%. And this is worldwide. And this is huge, because there are studies which have also come out that asymptomatic people who did not feel anything, there is 10% PAS incidence there too. So this makes you very concerned about this, 30% to 40% of COVID positive patients have lingering complaints. 50% of those hospitalized had lingering complaints, and 10% of those who are asymptomatic had lingering complaints. So that makes you estimate and project that 200 million people, 200 to 400 million people is all over the world are probably struggling with this. So I think that we have to have dynamic prediction models. That's why I think EHR and getting the real data is very, very important. And that's why I showed you the variant distribution, as well as the curve, the surge, that when do you get vaccinated, when do you do booster. So I do think that prediction models are helpful in order to understand that what are the disease mechanisms and the pathways through which PAS can happen, what diseases put you at higher risk, but the probability of getting PAS is definitely going down. It's more to understand once you get PAS, like what was in your disease history that made you more prone. Yeah. But it's very complicated. Yeah. And also, till last October, there was not a clear definition of PAS. There was the clinical case definition of PAS was only provided in October 2021 by WHO, which says that you have certain array of complications within 2 months of COVID diagnosis and which lasts for at least 3 months. That's now the clinical case definition, and we have an ICD code for PAS. But previously, different studies were coding long COVID in very different ways. So it was very heterogeneous phenotyping across the world. What is long COVID?
Ganesh, you have a question?
Yes, Dr. Bhramar, I was very happy to hear you emphasize the importance of getting basic statistics right, given all the hue and cry about deep learning and with lots of data. Though I thrive on that area. So, but I'm happy to be bashed up on this. I was also especially wondering, as like you talked about selection bias, I've also seen this projection bias, which is maybe you alluded to it, maybe I missed it, but that results from restricting the data to records that must conform to certain schema. So I mean, often in many places people are now relying on audio input, free form input basically. The tone contains a lot of information sometimes. So what are your comments on that? I mean, it also kind of alludes to multimodal input here, but then basic statistics might or statistics might itself might fall insufficient, right? So any comments on this?
No, I am not trying to really undermine machine learning methods. In my work, I do use a lot of advanced machine learning methods, but I think that sometimes we just get jazzed by just the method without thinking about what is the clinical question are we trying to solve? Who is my population? And this thing of focusing the data, for example, I have seen many analysis where people just take EHR and then focus on the complete people on whom you have complete data on this variable. And that's so biased because particularly for a lab measure, you are not going to get this blood test ordered unless you have certain symptoms and certain disease history. So I see more and more people forgetting about how data are made. And so I really want people to pay attention to how data are made and what is your inference question. And then obviously these relationships are not simple. So using a linear regression or a logistic regression often is not enough. You need to incorporate nonlinearity in the feature space, interactions in the feature space. So I'm totally up for machine learning methods. But after adjusting for the right kind of sampling, right kind of selection bias, right kind of confirmation bias, and I do think that the multimodal data presents a lot of challenges because you restrict it to a subset on whom you have all of these components of data, right? And so definitely, and confirmation bias, I think which is probably related to projection bias, it depends on your a priori thinking. So how can you make it create standard elements that everybody is going to follow? Harmonization of the phenotypes across electronic health record system before you merge them. Michigan electronic health records may be very different from the one at Fred Hutchinson. So how do I really combine them without paying attention to this? If I just get data and get very excited about the tools that I learn, you're only going to produce garbage information out there. And we have seen a lot of that during COVID, even with all the drugs that have been claimed to work just by mining the different databases, but they don't work.
That's very helpful. So I think in addition to the point you made earlier, right? First sanitize the make sure that you have sane data, and that could mean that you restrict yourself to tabular data, and thereafter you can open the field, create plugins basically for unstructured data as well. Maybe that's the summary of the message as I understand.
And the unstructured data is much more complicated, particularly for Michigan. We want the data to be usable for many people. It's very difficult to scrape off personal health identifiers. PHI information is most often there. So you have to have very specialized privilege to use those data, which are in voice messages or in clinical notes. We work only very high level security clearance will give you access to that data in Michigan. So it's very important to come up with standardized elements on method of extraction of there is a lot of papers in medical informatics now in extracting, say, data and content from images or pathological reports so that everybody sort of uses the uniform denominator. But still, that getting that data does not really address the problem. You only have this data on a selected population. Is that the only people you are interested in talking about? Or are you trying to talk about a broader population? You have to address that.
Thanks. Very helpful. Thanks a lot, Professor.
Shivli, do you have a question?
Yes, I have a question. Yeah, Hi, Professor Mukherjee. Yeah, hi. Very, very interesting and informative talk. I'm always learning something new from you. So I am very interested in this integrated data system because as I understand, only this disease counts not going to help. You need, like you are saying, official statistics, ecological data, social. So how? So you said US didn't have an integrated, data system. So how did you go about?
No, so we do have integrated data system in the sense that we do have the Michigan records all integrated. But the advantage of UK or having a national health system is that suppose I'm going to University of Michigan today, tomorrow I'm going to a nearby hospital, St. Joseph's, which is a local hospital, or Beaumont in Detroit, for another reason. But there is no linkage of all of these data together. So I'm assuming that when I'm not seeing an observation in Michigan health system, nothing is happening. But a lot of things are happening, which medical claims give us a more comprehensive capture because every time you see a doctor, you have to pay in the United States. So that is more captured. But a single EHR does not give you a comprehensive description of a patient's health history because you're missing many things because they are going to seek healthcare in other ways as well. So there are many solutions right now for United States. So, in UK, everything is in the national health system. So you can get a comprehensive capture of everything that's happening to you. Where are you getting vaccinated? When are you having your COVID positive test, say post vaccination? So you can say, what is the rate of breakthrough infection very easily. But in United States, it's not possible because I may not report my vaccination, which I got at a CVS pharmacy, right? So there will be very lots of missing data in a single EHR. And so we do not have that integrated data system. We are doing as best as I can, but I think we need to do better. Countries where all of the health encounters are captured. So I was very excited when the government was in India was talking about digital health ID so that all encounters are registered in a single database, including, your COVID testing, COVID vaccination, and then post-COVID healthcare behavior, right? So that's very important. Right now, we are doing a study where we are looking at people who had COVID, whether are they seeing doctors more frequently by comparing their pre and post COVID period. In order to this kind of studies, you need the longitudinal comprehensive data of what healthcare used to be. And so if everybody's all kinds of transaction with the healthcare system and encounters are captured in the same database, that's what I mean by integrated health databases. Because we don't have that, then we try to say, okay, this is what we have. Then in order to talk about whether this will hold in United States or in Michigan, in the state of Michigan, I need to do some survey weight adjustment to make my population look more like the population of Michigan or the population of United States. But that's not the ideal one. Having really national level, nationally representative data set. If you think about the sequencing data from India, it's really, really biased from certain locations. It is not a nationally representative sample. And the way we have set up sort of our data and machinery is that we get more of the data from urban, very privileged people who go to Apollo, who go to Max, who come to University of Michigan, and then the voices of those who are unheard continuously gets unheard. And it really accentuates the disparities in healthcare because they have no representation in the papers that we are publishing.
Understand, yeah. Very serious problem. Thank you.
Thank you. So in the interest of time, we will have to
I think there is another question from Dr. Das.
Let's take this last question, Dr. Das. A quick question and a quick answer, please.
My question, excellent presentation. My question is regarding the clinical validation of EHR data. So you mentioned about antibody testing in the slides. So here, what like in India, in hospital kind of setup, what we observed, like we see a lot of harmonization challenges between kit to kit. Even in the same hospital setup, we may be using 2 different kits or 3 different kits, and this antibody testing data is showing different results. And along with the post-COVID MIS or multi-system inflammatory syndrome, in many of the cases is showing like COVID antibody positive. So because of that, what challenges you face or we can face like in future for clinical validation of EHR data?
This is extremely important, and that's exactly why I think that our data scientists or a quantitative scientist sitting down and talking to the physicians is extremely.
Ladies and gentlemen, our next session is about to begin. May I request you to kindly mute your microphones and wait as we prepare for the session. Thank you. May I request you to kindly mute your microphones and wait as we prepare for the session. Thank you.
Ladies and gentlemen, we are delighted to welcome Professor Nitish Thakor, who will join us from Johns Hopkins University. Professor Nitish Thakor has a PhD in electrical and computer engineering from University of Wisconsin. His research interests are medical instrumentation, neuroengineering, neural signal processing, and clinical instrumentation, micro-nanoscale sensors, devices, and systems. He is currently the editor-in-chief of Medical and Biological Engineering and Computing and was the EIC of IEE Transactions on Neural Systems and Rehabilitation Engineering from 2005 to 2011. He is a recipient of the Award of Technical Excellence in Neuroengineering from IEE Engineering in Medicine and Biological Society and Distinguished Alumnus Award from Indian Institute of Technology, Bombay, India. Ladies and gentlemen, please join me in welcoming Professor Nitish Thakor.
Thank you. So we will. So the organizers, do you know how to allow Professor Thakor to share his screen?
Can I do my own presentation?
I think,
please, but we are.
I know I've already given him permissions. I think Professor Thakor can.
I don't see it on my screen, unfortunately,
just,
which will prevent me from playing some videos. May I just for 1 minute log out and log in? Maybe looks like I've gone to viewer mode.
Let me try once more, Professor Thakor, if you don't mind. I think we should be able to do that now. Can you try, please?
I don't, there is no speaker view here. I'm like a participant, so I have no button that says make a presentation or anything.
Maybe the one who is already presenting has to stop presenting. Somebody is presenting the.
So you are an attendee. So that's what it says. You are an attendee. You won't be able to share content or facilitate. So I am on an attendee mode. Let me log out and log in again to the link I was.
Changed. This is Prasad here. I've changed you to presenter.
Okay, but it's dismissed. I still am a attendee. So I don't know what, there is no, my buttons are video, mute, open share tray. Is that what it is?
Share,
then
share content. The one next to mic. Yeah.
This is the
yes,
one next to mic.
Yes, we can see your screen.
You see my screen, really?
Yes.
Okay,
Yes.
I see it. Unfortunately, it's strange. Okay, hang on. Just so let me see if my presentation shows up. Do you see my presentation?
Not yet.
So there you go. So I don't know what it's showing. I was hoping we would have a trial run. I didn't get a time window to do that. Okay, I'm at a loss. So I'm thinking, let me.
So Professor Nitish, your time has actually is not started, so we have time. So
let me either you fix it or I fix it by logging out and logging in again, and I might get a different mode. Okay, so I'm going to log out and I'll log back in again. I think since you're not able to fix it from your side. Again, I will see. Do I go to open share tray? It says only meeting organizers and presenters can share. So do you see anything?
We see a blank screen like before. I'm not clear why.
Exactly. So I have no idea what to do here. So then we will miss the video and we can just, in the interest of time, get on with the slideshow I've sent, which I'm fortunate that I did. It's unfortunate some of the videos were more useful.
Is it okay if I play your video? I have your PPT. I can.
No, that one doesn't have it. These were videos from internet just to make a point, but let's just go ahead because I don't have a presenter mode. That's all I can tell.
Can you try once more? Can you try once more? I don't.
You see, what I have is camera off, mute, and stop sharing, but I don't see any share. That's the thing, and then more actions and all those things. So I go to full screen. Yep, it's still, like Zoom or anything. Normally, I should be getting my own presentation, which is on the desktop and open right now. So if I stop sharing, then I don't know what I see. I see all your names, initials. I don't see anything else.
Oh.
At the moment, I heard all the presentations and all of that, but I don't hear, I don't see anything, any of you other than initials. And I've done Zoom before, so I don't know what's with the setting. So why don't you just put up my presentation and we'll just go with it. It's a little unfortunate, but that's how it happens sometimes.
Really sorry for this.
Abhilash, please present slides.
Okay.
It would be in future a good idea to give the speakers a trial run to debug it before the events. Generally, I'm used to it, and Zoom works much better than other options. Okay, so now I sort of at least see myself and something. Yes, okay, good. So yeah, go into presentation mode if you don't mind. All right, well, so good evening to you all, and thank you for inviting me. It's all of it is because of my association with IIT Bombay, right? So I continue to be very motivated and supportive of any activities going on campus. And I kind of play that role in some departments or Koita Center, of course, and then when IIT Bombay Heritage Front from the US side. So it's a privilege, and I want to thank you all for that. So can I have the next slide, please? Yeah, and of course, this is important. You know, it's an incredible privilege for IIT Bombay that the KCDH has been set up, just the right thing at the right time. You know, priorities change, and this is a perfect timing in the era of digital health and global health problems. And you know, seeing all the proposals and presentations even early morning, you know, IIT Bombay is very beautifully positioned. So it's going to be exciting years ahead. Next slide, please. Next slide, please.
Abhilash, can you move to the next slide?
Yeah, please, you know, you'll need to move the slides, otherwise
yes.
this will.
Okay.
Yeah, so please, okay,
it.
you lost the slides now.
Professor Nitish, have you logged in from your browser? Okay.
I attended early morning session. I attended Professor Bhramar's presentation. Please go back. You are completely mixing up the slides. Go to slide number 4, please. It would have been 3, but irrespective, please go into 3. You're going to 5. You're going in the wrong direction. Okay, you know, I just want to give a little bit of background. I don't know if their audience has students or not. So today, the interesting and important thing is that how the journey starts, right? I mean, I was a student, like if there are students in the audience doing something, but my BTech project way back in '74, before something biomedical was ever even cool on the campus. And you know, one thing led to another, and actually I reached out to an advisor in University of Wisconsin, whose paper I read in the library, on which I built my BTech project, which led to PhD and so on and so forth. And so over the years, my own life and career has evolved quite a bit different from the times that I was a student. So I hope that all of you probably share that life moves on, new ideas, new problems arise. So, you know, this is the KCDH, and what it's doing is the right thing to do at this time. And I wish I was a young student again to join. But let's go to next slide. Can you go to the next slide, please? Yeah, so this is about Professor Inti Banerjee, and I was really shocked and surprised that she passed away. I just found out through this symposium. So, you know, I just found this quote from her that is quite appropriate for the symposium here, that we continue to do science and innovation, and all the talks we have heard are about healthcare. In fact, Dr. Bhramar just, in fact, indeed mentioned something about inclusive healthcare and people who are left out. Can you go to the next slide? Yeah, you know, so I want to make slightly different point, and of course, I want to make sure that I give. This is about since mine is the last talk. I don't want to. I want to address different topics. So this is Dr. Banerjee's credentials that we tend to see when we look at academics. With this kind of credentials at her age, she would be full professor at almost any top US university. You know, looking at the citations and H-index, which is, you know, 40 papers with 40 plus citations. And what is also remarkable is the growth curve of her citations, which means she was essentially at the peak of her career, you know, which is quite impressive. Her specialties you see is biomaterials, nanomedicine, and point of care diagnostics and such. And I think she was starting to help with digital health and so on. So I think I'll kind of address those things through her own work. Next slide, please. Yeah, one of the ways that I hope the Koita Center faculty also pay attention and interest as academics, and then unfortunately my videos won't be there as translators. So there are two things that I wanted to touch. And one among the things you live as an academics is your publications, your citation, and you can see that Dr. Banerjee, even in the recent years, in the last decade, has number of highly cited papers. It's quite amazing to see such numbers in such a short time. And in variety of important journals, right? Drug delivery to biomaterials and so on. And so I hope that, again, the KCDH faculty will make both clinical and social impact, but also academic impact along these lines. Next slide, please. So I just took some example to kind of enlighten. And I mean, I'm generally familiar with a lot of the topics, although it's not relevant to this conference. But here is one of the very highly cited papers about using biopolymers and hydrogels for cartilage tissue engineering. Cartilages are avascular, and so some kind of, they degenerate with aging, even worse, and other diseases. And these kind of biomaterials, hydrogels and so on, can serve as a way to treat the cartilage degeneration. And you see a little injection device, which means you can even inject such gels, including maybe stem cells. So rather interesting and important work in the field of tissue engineering. Next slide, please. This is one of our papers about temperature sensitive magnetic liposomes for thermochemotherapy. And here is one of the another, again, very impressive thing is the longevity of this work over the more than a decade. Some other today citation index look at only last couple of years, and which works for hot areas, but longevity is also important. It's something I hope the work done, some of the, particularly the mathematicians, statistician, computer scientists, you don't get cited right away. It's abstract, difficult material, but longevity proves your expertise. Next slide, please. Dr. Banerjee also worked in the area of nanotechnology, the interface of medicine, tumor, and nanotechnology, so that the whole problem with tumors is to target to the cells. And how do you do the targeting? And so most emergent approaches now use some form or shape of nanotechnology, nanoparticles, biodegradable materials to get into the tumor, and they have to solve a number of problems. Unfortunately, I can't use the cursor, so you'll have to kind of view it that, on the left side, you have to get it through blood vessels. On the right side, maybe you use magnetic fields to push those kind of magnetically sensitive particles in there. And then there are a number of other ways to actually kill the tumor cells. Okay, so next slide, please. I just wanted to give a introduction on this, but again, you see that Dr. Banerjee has a number of papers, quite a few, on the nanoparticle for wound healing or tumor and glioblastoma and so on that I will discuss, and then later on some variable and implantable. But these are, what is remarkable is that these are 2022 papers. So that means her legacy is even continuing right now, which I find it astonishing and impressive. These are the 8 refereed papers that I have found just through a short review. So amazing. Next slide, please. Okay, so now kind of getting in the talk, and since we're moving a bit slowly, I'll skip some things later on. But like now, what you're now seeing is that the past, or Dr. Banerjee's work, and I know a lot of that also has gone on at all institutions. Nanotechnology was hot, tissue engineering was really hot, and now it's digital health, right? I mean, science moves, hot fields emerge. And I'm going to make a case study out of glioblastoma. It's a lethal brain cancer, to see if we can bring it all together. Okay, so next slide. And as I said, I may have to skip some things because we are moving too slowly in the slide shifts. So next slide, please. Okay, so part 1 is nanotechnology, and I see that Dr. Banerjee had a paper. It's a biomaterials, is a very well-recognized journal about wearable and implantable devices for drug delivery, application, and challenges. So, delivering drugs and that too using biomaterials has been an explosive field And throughout the US and major institutions, you'll see bioengineering departments full of researchers working on this area. Next slide, please. So representing what Dr. Banerjee did and generally the field, it's about things like drug-eluting lens on the upper left-hand corner. Lately become very popular, which may apply someday, who knows, for a certain type of cancers and vaccines and such, is microneedle patches, which you see in the bottom. So that this is now way that glucose testing is being done. Drug-eluting stent on the upper right, on the right side has become very much a commercial clinical business for stents for the heart. Next slide. Next slide, please. Yeah. So here again, going back to Dr. Banerjee, then can you go back, please? Yes. So she worked in the area of wound healing. So you can see that wounds have to be treated, and again, delivering stem cells, nanoparticles, antimicrobial drugs, all of that is important. And on the right side, the review kind of captures a lot of buzzwords, but these are cutting edge materials that can be used for a variety of tissue engineering problems, including wound healing. And wound healing angiogenesis, which is blood vessel formation, is very similar to what happens in cancer, which we'll talk about. Okay, next slide. Next slide, please. Yes. Okay, so I'm off topic in a digital health community, but hey, you get to know something new today. And so everybody sort of heard of nanotechnology buzzword. These are like 3 or 4 amazing cutting edge things, carbon nanotubes and graphenes. This is sort of like Nobel Prize living work because carbon in graphene and nanotube form is monolayer. So it has now finding profound application. Quantum dots and gold nanoparticles are potentially a way to image or colorize. So now start thinking about cancer, glioblastoma that we're going to talk about, that these things can be used for coloring the cancer or the treatment. Next slide. And so, the question is why nanoscale? And again, today, of course, we are all thinking of COVID and COVID vaccines and so on. And I wouldn't be surprised that some biodegradable formulations will come out. One of the pioneering Moderna company is co-founded by Dr. Robert Langer, who is world famous, and he's famous for biodegradable delivery. And so, sorry. Okay, so Dr. This biodegradable delivery of vaccine, who knows? But any case, it's an option to studies, drugs and disease and treatment, and scale matters. So you see the pictorial representation. A lot of things that causes health problems are tiny, nanoscale to microscale. Next slide, please. There is a scale in the nervous system, which is a bit my field. I'm going to actually skip all of my work because of lack of time. But in the brain, how do you get? And again, focus will be glioblastoma and then the use of AI in digital health. So you have to understand a little bit about neuroscience. So the domain knowledge, even though you may be involved in digital health, is important. And scale here is synapse, which you see in the middle, neurons and synapse and ion channels. And the challenge is to getting the drug or the treatment to those in a vast 80 billion brain cells that we all have. And so nervous system interfacing to nanoscale is another challenge. We'll leave it for some other day. Next slide. Next, please. Yes. Nanoscale, this is what I look back to my IIT days, and I feel like the fundas, as we used to call that, I use them, right? Because these solutions are optical, magnetic, electrical, topographic is mechanical. I was electrical engineering, doesn't matter. I, in my own way, have used each of these physical, chemical modalities and associated either engineering or mathematics. And so this comes together sooner or later if we have good fundas. I just hope, I'm sure all scientists recognize that. Math and statistics at the top of the pyramid, I would say. But OK, next slide. And so in my work, in my field, this type of thing is neurotechnologies have now become very prevalent. Each one of them is a commercial and clinical solution. And I hope I have time to say how to make a clinical impact. But every one of these machines you may have heard of and seen in some other ways, some like magnetic resonance imaging on the right, obviously, and other things like artificial vision is become reality. FDA has approved, and my work on artificial limb and sensors is happening as we speak through startups and such. Okay, next slide, please. Next. Next slide, please. Okay, I think I'm going to have to start skipping the slide. So please, whoever is moving the slide, can you be attentive because we will be here forever. So we'll just have to skip some of the topics. The kind of work that on neuro nanotechnology that I work on. Can you skip it? Let's just skip this. Skip them. Skip this. Next. 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 Next, please. Next. Next. Okay, next. So I think one, I want, okay, that's fine. Previous slide, you might have seen it, but I want to make a transition to one disease problem and then transition to digital health and how to make an impact. And so here is the nanoparticle, nanotechnology. Said we did tell you about gold nanorods. They can be delivered to a tumor to somehow heat it up or deliver the drug. Okay, so next slide. So since Dr. Banerjee did work on tumor and glioblastoma, and I know something about it, I thought I can elaborate. Glioblastoma is one of the most lethal cells. When you get a diagnosis, you have about 6 months to live. And through these kind of nanotechnology to other topics, it's now life expectancy after such diagnosis might be about 1.5 years. So it is the most lethal diagnosis you can get in among many. Okay, so next slide. And here I wanted to point out Nanoscale is an important journal and it's a 2022 paper. So I think either, it's just come out, I would say. And Dr. Banerjee worked on this intranasal route to delivering, because the problem is how do you get anything to the brain through the blood-brain barrier? And if you can go through nasal mucosa into the brain, I mean, wouldn't that be incredible? And this is a mouse study. We're not going to go into any data today, just to appreciate high quality work and how it can make an impact. Of course, going into clinical will take a long time, but here is some pioneering work, just very recent. Next slide, please. So for those of you who don't know anything, it's why clinical motivation. And I was pleased to see in the morning that everybody started with the clinical motivation. So here is a brain tumor. It's very aggressive. Next slide. And the therapies are surgery, radiation, chemotherapy. As I said, today at best 12 to 15% month survival. Next slide. And sorry about the pictures like this, but this is what a surgeon sees, and they resect the tumor. And how do you know where the tumor ends and a healthy brain is? And if you take out too much tumor, you lose the brain. And if you don't, then you have residual tumor cells, which will come back. This is what generally happens. And lighting it up by different methods, optical and others. And then for digital health people, I'm going to make a case about digital biopsy, maybe a way to go. Next slide. Next. Yeah. So, this is, we'll go through a bit rapidly because of the time. But these are optical images that can show you in tumor in a vivid manner that it's after skull removal. These are our rodent type studies. So you can look at tumor, blood vessels. Tumor likes blood vessels. It needs to grow. Eventually, then it kills the tissue. So optical techniques that look at blood vessel oxygen is very important. Next slide. And studies like this are done initially in mouse and rodent study. I'll skip it. Next slide. And you can see that if you do some treatments, such as with laser and nanoparticle, this little gray stuff you see is tumor, and it is reduced. And of course, the challenge is how do you go from rodent study to human studies, which is a lot of the clinicians today would want to know, right? And that's the challenge of academics. So this is what I'm trying to use as an example of what challenges we're going to face, is from basic study to how to translate in a realistic time manner. Next slide. So there are, again, a variety of ways to look at the brain and tumor using optical and looking at oxygenation in the brain and blood vessels in the brain. Next slide. And then the key challenge a surgeon would face is, where is the tumor and where is the healthy tissue? Like, is there a dotted line? And why am I even presenting it to this digital health community? Because I think that there's some degree of evolution and consensus that we'll need some kind of digital biopsies using AI, machine intelligence method to do this classification. The biology and materials has only gone so far. So next slide, please. Yeah, and so this would be an image-guided surgery. You can see there is a tumor, and you can see it's gradually diminished. On the right side, you see that there are different types of nanoparticles and laser techniques do prolong life. Now, in this case of a rodent, but hopefully it will apply to patients. So elongate the lifespan. That's what we all want, right? Next slide. Okay, so here we are, state of the art. MRI, fluorescence, like colorizing the cells, intraoperative, during the operation, even, and what is the future? It could be intraoperative imaging and AI, digital health, to do all this in real time in a classifier based on some of the prior knowledge. Next slide. Next. Yeah. And you know, this is one of our studies done in a rodent, but you know, you can see this little, just follow the little red circles that, you know, good microscopy, good imaging, you can see this evolution of a tumor's lifetime in a rat over 15 days. The trick to treating tumors is early detection. Is that in the number 1 or 2 dot, the beginning of a tumor? Can machine intelligence pick it up? Somewhere in the middle, it's really bright because there's a lot of blood vessel and oxygen the tumor has hogged. Is that a region that we should surgically resect? Or towards the end, did we get everything out, or did it spread, and so on? So imaging has done its part. Nanoparticles and things have done their part, but we don't have the intelligence to deal with this. So unlike your large digital health problem, this is wonderfully constrained problem with animal model and a clinical model and life issues. And I hope somebody will pick it up as a digital health problem. Next slide, please. Yeah, so this is where unfortunately my videos would have been very useful. This is a picture, Johns Hopkins Hospital, but the 2 people involved are Robert Langer on the left and Henry Bram, a neurosurgeon on the right. And they're both world famous. And Dr. Langer for his biomaterials, biodegradable materials, probably the most cited engineer, if not a scientist in the world. And Henry Bram is world-renowned neurosurgeon who made the first treatment of glioma happen. So I think today what I saw and what's happening in KCDH, this partnership, I wanted to show this and their video, because that would show how physicians and engineers, and nowadays computer scientists and mathematicians and statisticians could work together. And they made an impact, which is really what we want to be able to achieve, right? So I started with talking about impact in terms of publication. Now I want to talk about impact in terms of treatment, human outcome. And it's not great, you know, 6 months to 1.5 years. So in fact, this is challenge and work continues. Next slide. Okay, so sorry, there are no videos, but now we're going to transition. And so where does digital health come in? Next slide. Next, please. Yeah, so here I just took glioma, right? This is that lethal brain cancer. And look at what's happening in the publications count. And it's exploding, right? As I have shown, we might have started with biomaterials, then all the nanoparticle, then all the imaging, and now these imaging combined with AI to localize where the tumors are and how to resect. And I would say that if we go further, it'll be things like digital biopsy might be the future. And this is what I hope KCDH faculty would aspire for, right? To see they're part of this change, the pioneering change. Next slide. I think there's not the point to give a tutorial on AI. There are the buzzwords about AI and machine learning and neural network and everybody's favorite deep learning, but this is getting, it's working. I saw one presentation about retinal images, but everywhere. So there are great deep nuances of these techniques now that are coming forward. So of course, we may all need to collaborate to make this work. Next slide. And if you want to do one slide tutorial on deep learning or convolutional networks, you're going to start with these brain tumors, the left side. And, again, I saw the talk about, talks where you have limited data. There aren't millions or thousands even of brain tumor patients or images. And so developing these techniques from sparse data and heterogeneity is going to be very important. So I was really delighted to hear some of the techniques that came out in some of the proposals and presentation, that it's going to be needed. It's going to be we'll need new form of deep learning, machine learning. Next slide, please. Yeah, so here, is there a smart way of segmenting tumor? Is there a guidance to give to a surgeon where to cut it? And we have seen another video that I had wanted to show was about mammography and very recent results. I don't know whether it's from Google, but somewhere that, yep, radiologists could not pick it up from mammography, and that AI machine intelligence in some form did a great job. And this was a scientist who worked in AI, and it was her own breasts she went back to old images to new, and that's what happened, right? So this is a astonishing example of how machine learning and AI could be helpful. Next slide, please. So what might well be this kind of future workflow, right? We could get these MRI, some of you are working on vaccines, others are working on other public health issues. Then you're going to start working with IIT faculty who are doing segmentation and deep learning and all those things. And they're going to keep working. The students will go deep into this data, and they're going to do feature extraction and so on. We saw and heard in the talks that there is a lot of other data that I've just emphasized image for focus, but age, gender, clinical, genetics, all of that. Then I heard the talks about and asked the question about predictive models, because, that's going to be really important. And, on the right side, there are some biomarkers, genetics and molecular. And finally, the goal is to achieve prognosis. So I would say this will be the future workflow. And increasingly, it's going to go from traditional to more futuristic, computational, and data intensive. Next slide. Yeah, it's a little bit more of the same. It's AI. So this is the point I have been making, that AI guided treatment, like a virtual biopsy, right? You get these images, maybe you have prior knowledge, and you have all kind of other information about genetics and patient information and so on. And then you do AI virtual biopsy to understand where to cut, what to treat, and then predictive outcome. So this would be potentially a model for these kind of rare but lethal diseases, somewhat different than vast epidemiology problems that we heard about. Next slide, please. Yeah, and I hope therefore you see these challenges and role, and you can substitute glioblastoma with something else if you like. But since I'm the last person wrapping up, we heard about limited data and annotation. It's so remarkable that I had this slide sitting there and I heard a talk about that as a problem. Model training, which, right, so all of this from large data set to small. And then we are what has been most impressive for me, and happy to hear how your faculty have reached out to the physicians in Mumbai, but also elsewhere, to create these consortia so that they can create the standardization, benchmarking, and annotations, and then eventual interpretation and treatment. So I think these are all three equal challenges looking ahead. Next slide. So hit the return, next one, just it'll continue, add some text. So, today I started with nanotechnology, maybe it was off topic, but I hope now you see it all come together, that, this whole thing about blood-brain barriers, targeting glioma cells, nanoparticles, nanotechnology, and I wouldn't be surprised there are people doing that in bioengineering and elsewhere. And now you are the new community who is into AI and digital health. So you could go into tumor margin detection, understanding angiogenesis, and then develop image-guided virtual biopsies. And your challenge is what we saw in the last slide: data, models, algorithms, and clinical deployment. So perhaps my talk kind of pulls it together for you that cutting-edge technology, because IIT is an engineering institution which is transitioning into broader topics. There's a lot of expertise along those lines, and emerging and modern computer science, AI, statistics, math people teaming up is obviously the future. Next slide, please. Sorry, so we won't have video. So I want to end this again in appreciation of Dr. Banerjee's work, which was inspirational. The more I studied, it seemed like, how impressive, and makes me proud that IIT is producing faculty and students who are of that world-class caliber. Some of the industry folks get a lot of publicity, but academics are what made the institution. And of course, Koita Center and its resources, and now the benefit of new grants that are going to initiate a number of wonderful projects. I think I'm concluding maybe the last slide. Next, please. Yeah, so okay, so thank you. Maybe I believe this is it. So if you could turn the screen off, and hopefully we have a little bit of time left for discussion or on any topic. So turn the slide off, please. Yeah, turn that off so we can see each other. Yeah, okay.